Good morning, everyone. Now we're all energized after our morning session. We're going to dive into what I think is a fairly interesting topic. It's about setting limits and recognizing boundaries. I think it's important because we are systematically trained to do exactly not this. We are taught to push limits, blur boundaries, only then you're a dedicated surgeon. So it's an interesting outlook. So, at the outset, let me proclaim a few disclaimers. I'm not an expert. I have zero knowledge of psychology. Sometimes I don't understand my own psychology sometimes. And I am notoriously bad at setting boundaries. I tend to overextend myself. But I am learning, and I realize that some things that we do in the interest of self preservation is exactly this. We are setting boundaries. So I just like to share some insights I've gained through my personal struggles, and maybe something that several of you might be able to relate to. So this is strictly gender neutral. I believe this is an issue that resonates with men and women equally, nothing more to each side. And so we are going to be gender neutral in this discussion. And so we know what we headlong jumped into the moment we started this field. Surgery is a demanding field, long hours, complex patient decisions, life death situations that are emotionally draining, almost zero work life balance. So it is a breeding ground for stress. And when I first joined surgery, there was a professor who was famous, or rather infamous, for saying this. And at that point, it was okay, that's the norm. That's the code. You get used to it. Long hours, constant demands on your schedule. You sleep when you can, you eat when you can. That's the way forward. That's the only way. That's how all of us trained, I'm sure. It was the norm. Sorry, I think they've changed the. I'm so sorry, I think. That updated version you didn't save? Okay, sorry. Okay. So basically, a surgeon is supposed to be talented, tireless, total devotion to the job, and always willing to go the extra mile. So, patient before self, hospital before home, no questions asked, and no whining, no complaining. If you have any issues, you keep it to yourself. You just grit your teeth and bear through. That is what we were all taught. So, anything other than that is a sign of weakness and should not be displayed. So there's a fine line between dedication to the job and overwork. And if you're not careful, if you fall into the abyss of overwork, it can be a downward spiral. It's self destructive. And as we heard yesterday, it is going to lead to potentially dangerous situations for your patients. So, this is an article that I came across written by a second year general surgery resident who was training in a public sector medical college. So she was talking about the average weekend in her life after coming off a 48-hour shift where she would only be relieved the next day evening. She was describing her experience of being physically, mentally drained, and questioning how, is this humanly possible? How can I sustain this for 2 more years? And if I can't, am I, self-doubt creeps in. Am I not cut out to be a surgeon? But I can't say anything. I'll just bear through because I can't be seen as weak. I'm sure even men feel the same way. And you'll be telling yourself, yeah, that's how we all did it. It's a rite of passage. So, yesterday we listened to a fantastic talk about burnout. So, some of the elements are overlapping because the idea of boundaries is to prevent burnout. Just like Dr. Reddy was saying, he was nervous about following suit to Dr. Fernandez. I'm also a bit nervous because, I have to follow suit to what we already discussed in length. But interestingly, if you search burnout in PubMed, from when it was first described, as Dr. Reddy said, 1988, over the last maybe 4 years, there's a tremendous increase in interest in burnout, especially among surgical profession, especially after the COVID pandemic, when people were really pushed to their brink. So it begs the question, so wasn't it happening earlier when our professors were training or when they were young? Was it just, not happening? I'm sure some of the senior surgeons in our fraternity will be telling themselves, yeah, that never happened to us. We were made of stronger stuff. These younger generations, they're just not cut up for the thing. They can't take it. They're too sensitive. Maybe that's what they say. They're not resilient enough. So we know that Narayan Murthy quoted controversy recently when he said that, youngsters should put in 70-hour work weeks. That's the minimum you need to be productive. People who can't do it are, just not good enough. But I think us included, but even, the millennials and the Generation Z, they deal with different kind of stress. It's not the same. So there's a lot more competitiveness, a lot more patient load, parent pressure. Social media is a big pressure as well. So it's a different kind of environment, and I don't think it's fair to draw direct comparisons. And also goals are different. So Sir was saying yesterday that work-life balance may be more of an issue for women. I don't think so. I think even men nowadays want work-life balance. They want time at home with their families. They want to be part of child rearing. So it's an issue that is pertinent for both genders. So work-related stress is a real problem, and maybe it's just that it was never reported. Like we said, you just, push through, plow through, and don't talk about it. So it was never reported. It was ignored. Often we think, okay, let me get through residency, then I'll start thinking about myself. Then it becomes, once I become an associate consultant, I'll start thinking about myself. Once I retire, I'll start thinking about myself. So we keep postponing our self needs for the interest of work. That's how we all function. That's how we cope. It's a coping strategy. But this is not sustainable. In the long run, this will prove self-destructive in some way or the other. And I think that's at different points in our careers, we would have felt that, you can't keep going this way if you want to keep functional in all realms of your life. So that's what we were talking about burnout yesterday. So I think, again, I personally, fairly recently went through a phase where I felt, on the brink. So I relate to this picture a lot, because when you're trying to be there, your best self for everyone else, there's very little left for yourself. And I think that's important that is paid attention to now, because traditionally we're taught not to do that in surgery. So we all go through some periods of stress. You're able to recover. But when you're chronically fatigued, those who have resilience may be able to bounce back better through one or several periods of stress. But if you reach that point of exhaustion already, you're morally very depleted, any further stress can push you into burnout. So again, I'm not going to go into the details. We went through what it is, how to define it, what are the various realms. But this is a word cloud that kind of explains all the emotions that one may feel when you're feeling burnt out. So I don't think it's just about long hours. It's not like you take a vacation and you come back, you're all good. I think it's much deeper than that. It's a cumulative process. Daily high pressure situation, emotionally draining environment. You don't have a control of your schedule. You don't have the luxury of always, having a home life to bank on. So it leads to resentment, isolation, and that's what results in the ultimate apathy. So it's a long drawn process. Just taking one break for a week and coming back to the same routine is not going to solve anything. So it's a normal response to abnormal stress. And it happens to the best of us. Actually, if you see, we have this tendency to think, oh, it's the lazy ones, who keep complaining. But actually, burnout is most common in the dedicated, hardworking, perfectionist type of people who, when they feel the extra need to prove themselves, they will work extra hard against their own better judgment, their own health needs. So actually, burnout is commoner in the sincere ones, actually, which you think is, counterintuitive. So it's not a sign of weakness. Don't dismiss it as a flaw, as this person is just not built of the stronger stuff. It's not. It can happen to the best people. It can happen at any point in your career. So burnout was described by the psychoanalyst from America, who described a 12-stage process of a downward spiral. But ultimately, even though it's an individual struggle, the pressure comes from somewhere. So it's an organizational issue. It's a systemic problem. So there's this constant need to prove yourself, and that comes at the cost. So you work hard, often at the cost of neglecting your own needs. So that's, I think, where the limit and the boundary comes in, where we have to say, enough is enough. This is what I cannot do in your own interest. So I circulated the survey amongst various social media groups of GI, HPB surgeons, and our own women's surgery group. Not many responses garnered, 56. But I thought I'd just share. So about majority were in the 30 to 40 age group, and 60% close to were men who responded. 40% worked as residents, followed by junior and then senior consultants, and mostly in institutions or academic setups. So the tool I used is a validated questionnaire to assess burnout called a Maslach burnout inventory. So we talked about the 3 realms of burnout yesterday: emotional exhaustion, depersonalization, and personal achievement. So in each of those realms, there are questions with a graded response, and a cumulative score gives you each output. When you have a high emotional exhaustion, high depersonalization, and low personal achievement score, you're highly burnt out. That's how they graded it. So just to tell you, about 1 in 5 respondents had high emotional exhaustion. This was more among the 30 to 40 age group. Again, a point that Dr. Reddy reiterated yesterday, because this is once you get older, your coping mechanisms are better, the stress you're under is better. It's actually more in men than women in this cohort. And as expected, the group that feels it the most is the residents. So those are proportionately more who are under the stress of emotional exhaustion. Depersonalization, a third of people have started depersonalizing or detaching from the patients that they're taking care of, which is again not a good sign. Again, more in the 30 to 40 age group, proportionally more in women actually, and again more in the junior designations, the delegates, the residents as well as the junior consultants. 46% of respondents feel a sense of ineffectiveness or inadequacy in their personal achievement. Again, more in the 30 to 40 age group. Possibly those who finish residency are trying to get a hold on their career, not able to achieve, and compounded by the other feelings of exhaustion, they feel they're not achieving enough. More in men in this cohort. And again, more among juniors and residents. So if you go by the criteria of high emotional exhaustion, high depersonalization, and low personal achievement, one person fit the bill of significant burnout. It was a man, a resident who's 30 to 40 years old. So like I said, this is a gender neutral topic, equally applicable to both sexes. 6 are on the verge, either or. So it is something that is prevalent in such a small cohort. We're finding these kind of numbers. So you can imagine on a larger scale. Just some points. I know I'm running short, but I think it's important. 3 people felt that they're at the end of their rope every day. Every day they feel they're at the end of their rope. They can't take it anymore. 14% dread waking up and going to work in the morning. 2 people have already started seeing their patients as objects every day. Pink is every day. That's how they approach their patients. And this is about 2%, again, 5% who never feel that they accomplish anything worthwhile in their jobs. So these are small numbers, but the implication is quite significant. These are members of our fraternity who are feeling these things. So how do we address this? It's about achieving boundaries. So boundary is a demarcation that tells you what is mine and what is not mine, simply put. So drawing healthy boundaries, I think, is the key to prevent burnout and mitigate the risks of burnout. So it starts with making healthier choices, and deliberately so. Making deliberate choices, knowing that, okay, I'm going to trade off something. I'm going to take on rest responsibility. That maybe means that I might not be included in some decision making, but for my own well-being, I have to take that decision. So doing that, you're actually gaining resilience so that in a moment of stress, you have a better reserve. So across HR, corporate sector, offices, multinationals, they found that establishing boundaries is actually leads to better productivity. It reduces burnout. So why not in our profession?
Dr. Gayatri, sorry to interrupt. I think we will not have time to discuss if you take a little longer. Thank you.
So I'll skip then. So I think what we need to underline is that self-care is not selfishness. This is something that I struggled with, when I want to go home early. Is it being selfish? Am I putting more pressure on my coworker? It's like the analogy of the airway safety instructions that none of us pay attention to on flights. If you have to put the oxygen mask for yourself before you can help your people with you. If you cannot take care of yourself, you're of no use to your kin and near ones. So you need to be clear on your needs, your limitations, 2 or 3 top priorities, and you need to step back. You can't pour from an empty cup. You have to be able to refuel, replenish resources. Only then you can continue to be fruitful. So I think important is it's okay to say no. So I'm going to go back on my earlier disclaimer. I think this is a bit more relevant for women because we're brought up to say, you have to be adjusting, you have to forgive everything. So it is okay to say no. So identify priorities, what is important to you, rank them, and the changes that can bring about the most resilience in your life. Commit, start with 2 or 3. I will put in half an hour of exercise every day. I'll eat healthier and maintain those. So I just want to say this, the importance should be on self-care. A lot of this is the part that is overlapping, I know, but I think it's important. Healthy eating, not just any random chips packet that you can get your hands on. Healthy eating, exercise, relaxation techniques, personal downtime. I think it's important that we have a life outside of work, whether it's painting, like Dr. Monica said, some interests or hobbies that are completely detached from the work, and regular medical care actually is also important. So, okay. So boundaries are challenging to implement, mostly because we fear the repercussions. What will my HOD think if I say, I want to leave early? What will my co-workers think if I say I can't do duty today or I can't do this extra research project? So there are fears of rejection and repercussion and discrimination following that. So saying no isn't easy. We want to keep everyone in our life happy, our family, our bosses, our co-workers, but it's important that you keep yourself happy too. So it's the people who thrive on your lack of boundaries who will reject when you set up your boundaries. But in order to function effectively and to have courage to love yourself, you will end up disappointing some others. It's difficult during training because you're expected to meet certain expectations. So you do what you can. At least among your co-workers, you have a good line of communication. Manage time, and unlike what that professor said, food and sleep is important. So is exercise and some strategies for managing stress. So a burning platform is an allegory from management exercises. When your system is in chronic failure of acute crisis, you need some form of drastic change. You need something that will acutely change the situation. So our burning platform, I think, is this. Burnout is a significant problem. It's not to be discounted as laziness or, they're just weaker people. We need to be able to instill some flexibility in our systems, deal with it sensitively, regardless of gender. Men are no different. They're also susceptible to the same issues that this faces. And we need some resilience at an organizational level. Adequate staff, infrastructure, stress, and workforce needs to be addressed with some form of psychological support. This change is required. Doing the same thing again and again just because it's the way it's been done will not lead to any progressive change. So I just leave you with 10 commandments of physician wellness, which was published a few years ago. Stress is your problem. You shouldn't take yourself for granted, and better boundaries is the way to go. Thank you.
Thank you, Dr. Gayatri. I think because of short of time, we will not have discussion for this session. I will request all the speakers to stick to time because people have to catch their flights today. So please be aware of it and do your presentations. Thank you.
I would now like to call upon our next speaker, Dr. Shruti Reddy.
Good morning, everyone. I'll just dive into the topic. So, my topic is surgical career and parenting. I initially did not want this because what I truly believe is everyone will have their own style of parenting. There's nothing to, there's nothing that I can tell anyone. Everyone will have their own style. But then, anyways, let's dive into this. I had some disclaimers as well. So this is not going to be a literature review. Personal decisions like marriage, parenting, etc., are actually more related to individual mindsets or social circumstances other than surgical career alone. Surgical career, especially for people in super specialties like us, it does play a major influence, but then it's not the sole factor. I am someone who believes that we can have it all, and my only concept of equality is this. I don't think that is equal. I don't think this is equal. So I'm not going to settle for less than 50%. At the same time, I don't want any special privileges. I can fight a man's game. Just give me a level ground. My views and experiences may not echo with everyone. So parenting is not a gender-specific role. But the very fact that it is being discussed in this women's forum means that probably we have a higher, a bigger role, at least in India, which is why this is something is what is being discussed here. This is something which all of us have heard during the start of our careers, at least, before 22 decades or, 15 years before when I entered it, I used to hear this a lot. There are only two kinds of women in surgery, the ones who should not be surgeons and the one who should not be women. So now I wonder what defines a surgeon, what defines a woman. But at the same time, should we be woke and call this statement completely wrong? So it's true that certain degree of resilience is required for surgical fields, and this is even the more for competitive or difficult fields like GI, transplant, neuro, CTBS, etc. But again, surgeons are conventionally seen as male, big or tall, aggressive, loud voice, flamboyant, or someone with a God complex. And because of all of these impressions that the society has of the surgeons, that, these kind of issues will exist. Women surgeons develop a certain amount of masculinity in them to cope through this. And perhaps if we kind of identify surgeons as just someone who is good at their field, who can practice the science and art of surgery, then all of this will not be an issue. And I think we are heading towards that. I'm seeing changes already over the past many years I've been in practice. And at the same time, what defines a woman? Gentleness, caring nature, sensitivity, commitment, emotional, etc., which are the personality traits which are usually associated with women. Isn't part of it stereotyping or social conditioning? I'm not saying there's no biological basis to it, yes, but there's a major part of this which is social conditioning. It's not that men cannot have all of those features. And at the same time, coming to parenthood, so we expect women to work like they don't have children and raise children like they don't have work. But why? There's evidence to show that child development is better in children living with both parents. Each person brings something unique to the child's life, especially during the teenage years. It's not always the mother. It's usually the parent who is of the same gender as the child who will have to step in for many roles, all the teenage issues that will arise. And it's other than the biology part, that is pregnancy and lactation, during the other periods of life, anyone, both mother and father, and sometimes even the extended families, can play those roles. It's not that the mother has to take the major role or should always be doing this. And also in India, I feel, this and beyond is what I would like to say. Parenting doesn't end when children leave the nest. It goes on until they meet their graves. So that's what India is. So we'll have to accept that. So there are Western problems. So this was a Royal College of Surgeons England commission project on DEI, diversity, diversity, equality, and inclusion. And they came up with a new field trust review in 2022. They've made some key findings on about leave and how the decisions play around the career, etc. And they've come up with their own Western solutions. But I don't think all of these can be, directly taken in India at least. And, again, we were discussing yesterday in the open session that compared to the other countries where the societies have a larger role, they have a bit of say, and, that is not the system in India. So we should probably, I don't know what is the solution to it, but anyways, I did this survey and I framed questions to capture data on career challenges that people are actually facing. I circulated this mainly in the women in GI surgery group, but I also welcomed some of the senior male faculty to give answers. So career challenges, what is the relationship of career challenges with parenting, and the relationship of career challenges with either gender or other factors. I received only 28 responses, 3 of them male, 25 female. This was the age group, most of them in the early years. Most of them are of early career grade, that is either trainees or junior consultant or fellow grade. This, again, the place of practice is a welcome change, or at least it's a pleasant surprise for me, because two decades ago, when I started off, I used to see most of the women surgeons mostly in medical colleges or institutional practice. Now many of them are in private practice as well. And so 25% of the women are single. There's no right or wrong in this, but my question is the career playing a part in that decision? And I think if we were to look at the male surgeons, the numbers would be much lesser. And the question as to, did your surgical career or training or career aspirations influence your decision of regarding or related to marriage? More than 75% of the women said yes to some extent. Majority of them said it was a major influence. What about parental status? This is what I feel is the situation, at least it is the case with me, and I feel to some extent it's there, that majority, many of them have a children or they are planning to have one, but many of them don't feel, so they do agree that it was a major influence or a minor factor in decision on having a child or timing it. And this is the age at which they became a parent, And so has your status as a parent adversely affected your career progression? So I think this is major challenge, minor challenge. So major challenge was identified only in 2/3 of them. The remaining of people managed to continue to do it without much of issue. What are the major challenges which were identified? So mostly in the younger group who would love to go into a fellowship, but they are unable to move their base. Some of them, one of the people felt that mom's guilt is something that she is suffering from. Question on shared parenting as to how many of them have partners who helped in parenting roles. A good number of them. So we can see this and this. So it's nearly 75% of them have a helping partner. What about the extended families or paid help for childcare? Almost all of them, 100% of them received some kind of external help. And is it consistent? Yes, it's consistent in majority of them. So this is something which the other countries don't have. This is the positive thing about India, that we have so many support systems for parents. I've just listed a few early parenting careers, challenges in surgical career related to pregnancy, timing it, fetal safety, and something which is not often discussed is people who want to go for infertility treatments. It's difficult to balance all of that with your career or full-time training. And fulfilling work and training requirements, we were discussing about it yesterday, that we can't knock off 3 months from someone's training just because they became a mother. And post-pregnancy challenges. Again, this is where I'll have to put that. So Piyush, when I went and told him that I have conceived and I will be returning to work early, and this is it was a surprise for me because it turned out to be a twin pregnancy, something I did not know. And Sir said that it's okay. These small delays will not make any big difference in the entire career. So thank you for that. Thank you for those words. The later challenges are the ones, I think the early challenges, we have support systems which can help us out. The extended family almost always steps in during that phase for any women. The later challenges are when we will have to find a way to balance it out or juggle it. So at work, the long hours, night duties, etc., it usually eases with time. But the other things like maintaining your ambitions, continuing to go to research, continuing to do research, continuing to attend academic meetings, networking, all of these things usually takes a back seat. And with children, there's always a fear that transfer of base, that is, you'll be separated from your child for a long time and it will have to be long distance parenting, and what is the stability for the child if you have to move the child with you every single time when you're moving base for the sake of your career. These are the challenges, which will be there. And we always feel that we are not giving our children enough of time. That's there, whether it's for a man or a woman, we always feel it's never enough. And the mental availability, sometimes we are physically with them, but in our minds, we are pondering something about some sick patient or something that you'll have to plan to build your program and those kind of things. And how to deal with guilt. I'll come to guilt in the next slide. And societal or school or peer expectations. Now, this is becoming a huge problem. I can say that there are so many schools and, upscale schools who prefer, children of stay-at-home mothers because they feel that the academic achievement of the child will be better if the parent is teaching the child at home, vis-a-vis with both the parents working or with the working mother, the child will not get that kind of attention and they'll get lesser grades. So this is mom's guilt. All of these factors, anyone can play this bingo and I bet we will get it correct in probably 7 or 8. It's okay. But this is an article which I found saying that it's nonsense. Part of it is manufactured by patriarchy and societal factors. As a concept, it takes advantage of a caring nature. It's a byproduct of repressed righteous rage as well at times. And many a times it has everything to do with the absence of the village that is required to raise the child. So I feel the first two things, early parenting and even the slightly other things, which I discussed in the second slide, which is like with the older children, the challenges, those things can be shared. Those things, the other people can step in and support. There are some larger roles which will have to be done by parents and parents alone, which is shaping the personality of the child. Yes, other people can help, but then eventually you are going to be blamed. What kind of upbringing you have, what did your parents teach you, teaching moral values, managing the teenage years. I'm probably 5 years away, but then I still dread it. It gives me shivers. Being a good role model. Financial planning for the future. It's not just that we are being good role models. We should always save for them. We should also take care of their, education and whatever. Marriage and their grandchildren and all of that, and supporting them into adulthood. So I'll just take 1 more minute. Supporting them into adulthood. And I think in a few of these things, working women can support the problems that the children face better. When the children come to the outside world, the problems which they face, it's, something that working women have already seen it, they've handled it, and they can support them better. Also, coming back to the survey, many people found the necessity to have support systems. Some of these challenges apply to all working women, not just surgeons. But have we noticed something that even within the same hospital, nurses usually have better childcare facilities. Usually there's daycare, there's creches, and there's flexible work hours, etc., which is not there for, I'm not going to say mothers who are surgeons, but any kind of, it can be a male or a female surgeon or any doctors, because we feel that, they are financially well placed, they'll be able to hire help, or they'll be able to take care of it in private daycares. Why should it be like that? And some of these are easy to implement. For example, can we have like a childcare or a play area in IASG? Like it's good not just for women who want to come to conferences. They can bring their children along, and this is a big deal in the West, that they're taking their children to the conferences and they're giving talks with the child sitting on the podium. So we can move towards that. There's also so many positives of parenting. It gives an added sense of purpose. The joy and de-stressing that comes with having a child, mental health, empathy. I'm not saying this is not possible for people who are not parents, but then all of this is an added thing that comes with parenting, and it makes us a better surgeons. And I always feel my kids are my strengths, not my weaknesses. That said, there are some other perceived challenges which I managed to pick up in my survey, which is many people identify gender as one of the major challenges in their career progression. This is women who have answered. And the biggest challenge when I asked them to identify, it was the first three, that is less opportunities, less reward, lack of equality, lack of equity. And something which should be gender neutral challenges, but then again, many more women identify this is related to gender, that is less opportunities and less reward. And again, lack of leadership opportunities. Many people say it's because of reluctance of employers or peers. And the major bias, or the source of most of the bias, was when gender was identified as the major bias, not parenting, not the status as a parent. And this one, the second chart, the bitter truth, where most bias is faced by women from their colleagues within the same specialty. So I had a section for the free thoughts. They said it's worse during their residency, patriarchal lens, moving to another city is a problem, opportunity as a leader is a problem. The personality is seen in a certain light, which is difficult. So this is my last slide, my journey so far. After I became a parent, I've traveled these two places in India with my children. So the children were 2 months old when I took them to IASG Con for the first time. This was my final year, and I did not want to miss that IASG Con, so I went with them. My family accompanied me. They are super supportive, and I really can't thank them enough for this. And this is when we went to Delhi, relocated them for the last 6 months of my training. I think in a few things, I am standing on the shoulders of my predecessors. My mother is a working woman. She's a gynecologist, and I was, my domestic care and my raising was partly by my auntie. So it was something which is not foreign to me. I feel it's okay for children to be raised by extended family members. I don't feel much of guilt in it. There's always a part of me which is sad, but then it's okay. My career is equally important. I have gone to these places in red for extended periods of time after becoming a mother. This was important for my career. This is something which I was already planning. At the same time, I did not want to postpone my motherhood to a later period and put my children at risk just for the sake of my fellowships, which is why I agreed to do it anyways. And these are all the people who have supported them during all this time. And their lives are a lot more colorful because of all the rest of them, not just because of me. So it's okay to take support. It's okay to not be great at everything or meet societal expectations. It's okay to make sacrifices in career for parenthood and in parenthood for career. So there's no right way. There's nothing like a perfect parent or a perfect surgeon. It just takes a bit of creativity to make both of them come together in your lives.
Thank you, ma'am. I would now like to invite the next speaker.
Can have a
on
couple of questions on this. Actually, we have, I think, 2 minutes left in this session. 1 or 2 questions, anybody has got?
Yeah, good morning, Dr. Shruti. I'm Dr. Sujana, one of the oncologists. Very nice and insightful talk. I could relate a few things. I'm a mother of 2 kids. So, yeah, the one part about the crashes at work and other things. Now there's a lot of gung ho about Paris Olympics, which is going on. They've set up a nice baby care area also there. So a lot of other factors, whatever you have put in, kind of like many of them we could relate as mothers. It's a very wonderful talk.
You're a mother yourself. Why don't you say, and you're in practice and you said that you're keeping it cool for now for the sake of your children. Why don't you share your views?
Yes, ma'am. Actually, you were an inspiration for me going into GI surgery. As I told you yesterday, I had got your notes too. So, this planning children and planning my career around parenthood has been a major thing for me. And yes, I am in the public sector right now because I thought that would give me, that would make me a better, give me better chance to plan my surgeries or whatever, not be put into rush by an external force as would happen in a corporate sector. So yes, ma'am, the first 3 or 4 years now, I think I'll be in a public sector before trying to expand.
That's okay.
A very
Thank you.
positive side to it. I'll just, so small thing. So if you can manage children at home, don't you think you can manage people at work better?
I meant
Yes,
the
because
amount of
everybody,
time.
the problems arise because people behave like children at work sometimes,
No, ma'am.
isn't it?
I think the amount of time I want to spend at home right now is much more. As my kid is like
I
1 year
don't
old.
think it's a different kind of professional attitude to it. I don't know. I don't think so in my experience, but I don't know.
Thank you. Actually, thank you so much. Actually, we'll end this session. I have the pleasure of introducing one of the most successful dermatologists turned cosmetologist, actually. With so much happening on the thing, actually, I'm not saying that this is what is required, but if you're talking about the me time, taking care of yourself, these are important parts of our life, actually. So I was trying to see who is the best person to talk to about this, and Rajita is she is a product of Jipmer, very successfully started her career as a dermatologist, successfully transformed herself as a cosmetologist, and if you see her clientele, actually it is huge. So thank you, Dr. Rajita, for sparing this time, and we're looking forward to your talk.
Thank you so much, sir, for this invite and for being a role model. Now, I'm probably the only surgeon other than the tech team, a non-surgeon here other than the tech team, and I should be feeling out of place, but I am not feeling out of place because Asian Institute and the Surgical Gastroenterology, particularly SGPGI, has been there as a part of my early growing up days in my 20s. We doctors grow up late, we all know that. So I was married to a gastrosurgeon for 16 years, and now we are happily divorced and happily remarried to other people. So, Dr. D.N. Reddy and Dr. G.V. Rao, their working styles have inspired me, maybe led me to the area of workaholism a bit too much. So the balanced talk was great. I heard a part of it. So over the next 15, this is not my timer, please correct it. Over the next 14, 15 minutes or so, I thought I should talk to you very accomplished people and make it worth your 15 minutes or 20 minutes. So I thought a surgeon is always a surgeon, female, male, whenever, wherever. So I'll give you a little glimpses of what we can do as a dermatologist for keloids and hypertrophic scars. But I'll talk about facial aging, skin quality, and hair loss, both for yourselves and for your patients, maybe for your family, for your kids. So what's new in keloids and hypertrophic scars? We have preventive modalities. We could do fractional laser resurfacing. Just pre-op, right on table. We could do repeated at day 7 to day 10. We could give botulinum toxin around day 7 to day 10. And we could do injection triamcinolone at the time of, I don't know if you people remove sutures any longer, but whenever it heals around that time. And all this is for people, not for everybody, but for people who have a tendency towards this. Now, can we do early intervention? Usually people come a tad bit too late. So when you have a tendency towards this, early intervention is great. So we have vascular lasers in addition to the various other modalities. So we have triple combination regimen, triamcinolone, 5-FU, not just the good old steroid and hyaluronidase. We have intralesional radiofrequency and we have intrakeloidal excision. So we've made a huge progress in this arena. Now, why should you people be listening to a talk about facial aging? You people are go deep, literally, figuratively, every which way. So is this kind of superficial to take, to get into vanity? Is it vanity at all? So most of us have a self-image of ourselves at 25. And when we have a discordance of what we see in the mirror and what our self-image is, then sometimes you have this kind of a discordance and unhappiness. And those are the people who come to me. And the other kind of people who come to me, and that is a larger group, they're not people who'd want to look young. All these CEOs, the film stars are a separate category. I will not talk about them. But all the surgeons, and I treat so many younger surgeons, but I don't treat many older surgeons of either gender. I guess they're too busy, or maybe they're not sure of what we have to offer. So I thought I'll show you a glimpse of how the CEOs and the tech giants are into this, not because they want to look young, but they want to look the way they feel. And the worst thing is, you've slept well, you're taking care of yourself, eating right, exercising, doing all the right things, and still somebody says, haven't you slept well? You're looking tired. And that's not what you want to hear. So what is it that we could do? Now, before I talk about anything injectable, people get scared. So Botox overdose cannot do this. Botox overdose, if you go beyond 3,000, you could kill a person, but you cannot accomplish this. And neither can you accomplish this. This is weight gain and badly done fillers. And then you would wonder if some of the richest people on the planet can end up like this. What about me? So you don't have to end up like that if at all you want to venture that route. So how do we age? How does the face age? There's a simple way of understanding it, the 5 Ds. So there is deflation, descent, deterioration, dynamic disarray, and disproportion. So let me unpack this for you. So when you deflate, you're losing fat, more so in the deep compartments of the face rather than the superficial ones. We women tend to lose bone very, very rapidly. We don't take enough calcium. We do not do enough strength training either. And then we also have muscle loss. And there's this particular sequence to it, which is why you have hypertrophy of certain subcutaneous fat compartments. At the same time, you're having loss of certain other deep fat compartments, which is why you end up with a defined cosmetic subunit, meaning in a young person, you cannot really decide where the eyelid ends, where the cheek starts. Everything is in harmony. Everything is fitting in very cohesively, whereas as we get older, that changes. So bone atrophy is very, very important. If there's nothing more you want to take away from this, remember strength training and calcium are going to help you age better. Now, what about deflation? Gravity is there from the moment the child holds the head high up. But as long as there is elastin fighting it, as long as your retaining ligaments are anchoring your bone and your deep fascia to the skin, it's going to hold up. But then once they become lax, because collagen loss is happening everywhere, so then you're going to have a slide down. And then we have deflation itself causing a descent. Imagine there is a nicely fitted tablecloth attached to the table, but then the table shrinks. So then you're going to have folds in that tablecloth. So that's precisely what happens when the skeleton shrinks and when the subcutaneous fat and the deep fat atrophy. So there are many things that you could do. And what we like to do is strategically place fillers so that we can prop up the retaining ligaments. So young face has got this inverted triangle shape, and there is no visible irregularity in the jawline. And here you see one of Hollywood's great beauties, a beautiful, well-structured, smooth jawline, and all the classic signs of beauty, harmony, proportion, symmetry, These are how we define beauty, and this is how she aged. So here you see not just the passage of time, but a life that's probably not been very happy. So that's not what we want to show ourselves and our others at the end of our lives. So you don't have to go through that. Sometimes you have severe drooping so much that there's a constant secondary candidiasis. And the only way we can get rid of this is to put a therapeutic dose of filler in the corner over there. So there are so many things that we do. And we Indians have some very strange lines. This line is called the Indian line. So it's not easy to restore those, but we could do it. Now, disproportion, as we get older, we actually become caricatures of ourselves. So this is me many years ago. So when I was younger, I had a smile that showed from incisor to incisor. And then because of the tissue laxity, I started showing from molar to molar. And now it's restored. So if I give you a broad smile, you'll see that again, it's back to incisor. And dynamic lines. So this is one important problem. Many of us start looking angry even when we don't mean to. So I started my own Botox journey when I do a lot of demonstration workshops. And there was a time when I was on Facebook, and every other week, some silly junior of mine would post a picture, and all my silly Jipmer friends would say that, you know, why are you glaring at the patient? Why are you looking so angry? And I realized I was not looking I was not angry. I was happy to be there, but I was concentrating. So sometimes you want to look the way you feel. So this is an option there. And the best time, what's the best time? Before you start getting static lines. So when you have lines that come and go, that is a dynamic line, and that's a great time to start off. And deterioration. So luckily, most of you surgeons are indoors all day long, except on holidays. We don't understand the concept of a weekend. I don't. Weekends are for conferencing most of the time. But when you do go in the sun and also in your car drive to work, please remember sunscreen is going to help you. So this is the picture of it's a very classic picture, American truck driver. His left side was exposed, his right side wasn't. So this is the difference between intrinsic aging and photo aging. And what about skin quality? So what is it that we could do if we don't want to put in too much effort and time? So one thing you could take care of is skin quality. So what is skin quality? It is even tone, it is glow, it is skin turgor. So there's so many things there, and this I will not talk about. And we Indians, we age by pigmenting. So many of you might have noticed that you probably were much fairer when you were younger than as you get older. Now, are we endorsing the fairness concept? No, fairness is not possible, and fairness concept in India is very unfair, honestly. So, and that is something you want to pay attention to, and I'll tell you what we could do. So how do we age? We Indians tend to have hypertrophic skin aging. So there are saggers, there are sinkers, and there are wrinklers, and we mostly are saggers because we tend to have way too much facial fat, we tend to have way too much visceral fat, and now we understand that buccal fat is the equivalent of visceral fat in the face. So what is it that we could do? We have these kind of layer-wise treatments. So from stratum corneum to the bone. Now what is it that I as a dermatologist could do for the bone? And so we call ourselves cosmetic dermatologists. Cosmetologist is someone who does makeup and all that stuff, pedicure and all. So for the bone, we have supraperiosteal placement of fillers so that you could stimulate the osteoblast to produce new bone. Whenever you put something under pressure, it becomes better. So how do we combine all these things? We prepare something called a treatment roadmap. So if it is a bulky face, then we want to contour first, and we want to fill laterally. Something called the line of ligaments is being described of late. So whatever you do outside the line of ligaments will not make you look like today's Aishwarya Rai. And then we have skin quality injectables, we have bioremodelers, we have topicals, peels, lasers, and we have energy-based devices. So we could use all of them depending on how much time you have, how much inclination you have. And if you have a slim face, then it's easy. You need to do far less. So a strong case for getting back to ideal BMI again, for whatever reason. So this was a lady who lost a lot of weight, around 10, 12 kgs, and she was very, very unhappy with her skin quality, with the way she looked. And this was just after a single HIFU. You can see that her double chin is getting better, and her jawline is reappearing, and this was at less than 2 months. Now, I'll show you one more patient's journey. This was a gentleman who came to me in mid-December. He lives in the US and he decided to work from home in India, spend time with his mother, and he gave me a month's time. So I did a whole lot of things. I had time to plan 2 sessions. So I used every possible device that I had. And then a month later, just a week after he went back, this was how his skin quality was. So his goal was fulfilled. He looked far less tired, and you can see the improvement in the lower lid area. I could have done a lot more if he gave me more time. So skin quality improvement and various other things we could do. Now, you could age in many different ways. You will have to decide on how you want to. If there's nothing more that you want to do, then do at least sun protection when you are out there. Do LEDs, do CFLs need protection from? No, you don't. Only when you're in the car, out and about. A gentle cleanser next thing, moisturizer, and then if you have more energy, then a single night cream with either a retinol or a retinoid or one of these. So I don't know how many of you are in Instagram. I've not found time for it, but I know that there's a lot of talk over there, so you don't have to. Now, in case some of you are thinking that facials help, no, they don't. If you want relaxation, I would suggest a pedicure. It's far more relaxing. Now, what about hair and the gastrosurgeon? So I thought I should talk about how hair loss affects your regular patients, because you do very aggressive surgeries, and I'm sure many of you become like their family doctors, and they ask you about every possible advice once you've done a major surgery for them. So acute telogen effluvium post-operatively, all it needs is we have many peptides which halt the hair shedding, and then nutritional correction, reassurance. But lots of times this surgery brings out the female pattern hair loss component of it. And what about your bariatric surgery patients? Even more so, and for yourselves. So every woman beyond the age of 50 is going to have some amount of thinning, and by the age of 50, at least 50% women have lost significant volumes, particularly in the frontal area, but you could also have a diffuse pattern. So minoxidil is the go-to, but there are many issues there. So what are the alternatives if one has significant female pattern hair loss? We have oral finasteride, we have oral dutasteride. We don't mind giving it after menopause because reproductive potential is over. We also have, for those who have hyperandrogenic variant, spironolactone, bicalutamide, a much safer drug than flutamide. And we have oral minoxidil, something that's almost like a no-brainer. It's a very, very safe drug. For hypertension, it was introduced in doses of 10 to 40. We use 0.625 to 2.5. And then we have interventions like PRP and stromal vascular fraction, which we get out of a lipoaspiration. So these are some of the results that you could get if you were on one of these things. These kind of results we could get with a whole lot of options. So this was me at age 27, a day before my son's first birthday. And this was me when I got remarried 5 years ago. Yeah, it was 5 years ago. So it's been a huge honor, and I hope I've given you 15 minutes worth. And a big salute to all of you and to the men who are with us, behind us, who walk alongside. Thank you. And I'd be happy to answer questions. Please. Yes. So I did not mention your part of that. Yeah. Oh, yes. We use it rarely because we have so many options, but a low-dose radiotherapy is still one of the things that is mentioned. And if somebody has large, painful keloids,
Correct,
then
yeah.
what do? We send them to you.
Okay, yeah. So just wondering, if it's still there in your algorithm. Thank you.
It's far less used now that we have so many other options.
Okay, I understand. Thanks.
I have a question. Nowadays I see a lot of youngsters, some of them I know who take collagen.
Collagen, yes.
Yeah, but I just looked up and thought, I read a little bit and saw that it actually doesn't harm, but it doesn't help. What is your take on it?
So when my patients ask this question, ma'am, I tell them, you eat egg. Does that albumin become your albumin? The same way this collagen will become collagen in the skin. So all these, you'd be surprised at how much of evidence is there about the use of this. All of them industries sponsored trials. You have even randomized control ones with carbon markers and all. It's like you said, it's harmless. So if somebody wants to waste their money on it, I say go ahead, but don't assume that it's going to do anything for your skin. Okay? It's a bit of a joke. So there is something called facial feedback hypothesis. Now, I am no authority in either being happy or in looking younger than my age, but what facial feedback hypothesis says is the happier you are, the less you frown. And the less you frown, the happier you become. It's like, you know, what you tell a child. Let's say the child is crying. What do we say? We say, stop crying, give me a smile. You know, that's what we say. You'll feel better once you smile. So there was a very interesting study where they had used botulinum toxin in the glabellar area, the frown complex, in people who had depression, which was not responding to first-line SSRI. So this was recalcitrant depression. So they compared botulinum toxin only in the glabella with a second-line SSRI, which is supposed to be more effective. And they found that actually the botulinum toxin won. So I don't know if facial aging is better when you're happier, but when you get Botox, you probably get both.
So, take my comments in the way it is being given.
Sure, sir.
Don't take it personally. Is it part of profession? I mean, I learned a lot of things, but when I see that staggers, haggards, wrinklers, and caricatures, I want to go to your clinic. So is it part of the profession that you
No.
give that impression to people that
Of
you
course
don't
not.
age very well and then you need to be looking better?
So I get what you're saying, sir. So is it a sales pitch? No, it was not meant to be. And are we into this concept of age shaming, body shaming? No, not at all. But this is now, how do we communicate this much of information in a simple term? So my apologies in case I have hurt anybody's sentiments, because that is not that was not the intention. The second thing is, I think we become desensitized. Now I looked at surgeons from very close quarters, and I see that I guess you people are used to showing those pictures of livers cut open and torrential bleeding and punctures of IVC and aorta. And I've heard all these stories, 16 years is a long time. So I've heard all these stories. So just like you become desensitized to that, I think as a dermatologist, I'm guilty of maybe becoming a little desensitized and maybe using such terms, but no offense at all. And I take your feedback. Thank you so much. So if you're happy with the way you are, great. We Indians are not going to be at risk of skin cancer, so don't even bother with sunscreen. Thank you so much.
Thank you so much.
Request Dr. Gayatri and Dr. Shruti to please come on stage. I would request Dr. Sujana Priya to please hand over the certificate to Dr. Rajita.
Jane.
I would Dr. Shravanti to please hand over the certificate to Dr. Gayatri. I would request Dr. Madhulika to please hand over the certificate to Dr. Shruti. Yes. And Dr. Sujana ma'am, please. Dr. Shravanti. Dr. Madhulika.
Now we move on to the next session on publications, research, and innovations. For that, I would like to call on the dais, the chairpersons, Dr. Swapnali, Dr. Mansa, Dr. Shraddha Patkar, and I would like to request our next speaker, Dr. Swati.
So, good morning, everyone. My topic is research, innovations, and women. So, I'll be talking about this in general because the next topic is on GI surgery. So, when I was given this topic, the first picture that came to my mind was this Marie Curie. We all know about her. She received 2 Nobel Prizes in physics and in chemistry. So, talking about Nobel Prizes, we do have Nobel Prizes even in medicine or physiology. So till date, there have been 224 awardees, but out of those, only 13 have been women and none of them surgeons. So, is there a dearth of female innovators? So the research, whatever I've searched, I found some innovators of surgical instruments or from 18th, 19th century and 20th century. So I found this. She's an obstetrician, Dr. Mary Harris Thompson. So she devised something called the abdominal needle. I couldn't get the picture exactly of it. And then we had Letitia Mumford Gear. So she designed the one-handed syringe, and she actually was a nurse. And then we had Dr. Margaret Butler, who's a ENT specialist. So she designed the tonsillar snare. And we had Mathilde Schott. She was the first one who designed this detachable scalpel blade. So earlier we used to have the single blade, and this used to, the sharpness used to be lost over time due to autoclaving. So she was the one, and she was not a surgeon, she was a biomedical engineer. Then we had Patricia Bath, who's a ophthalmologist who invented laser phaco probe, and Alexa Candy, who's a neurosurgeon who devised this anti-siphon shunt for hydrocephalus. But so these are very few names. So there are articles which say that the number actually might be much higher. But so these certain inventions may not have been patented. But then even then, considering the denominator, it's not enough. So coming to surgery, hepatology, gastroenterology, so some of these are pioneers. We all know them. Dame Sheila Sherlock, the first hepatologist of UK, Angelita Habergama, Nancy Asher, the first female to do a liver transplant. Dr. Muthulakshmi Reddy, as pointed out yesterday, instrumental in the Adyar Cancer Institute development. Dr. Gina Brown for the MRI cancer staging. Dr. Mary Lucas, the first female surgeon general of India. Dr. Mary Edwards, the first female surgeon. So what about the academic surgeons, female surgeons? What does the global data say? The global data says that 1/3 of the female surgeons in the world are females, but this also includes the OBGY. So if you exclude that, the number will be even less. So the US, the surgeons constitute about 22%, in Canada about 12%, in South Africa about 20.7%. So what about women in academic surgery? So in this study about women in academic surgery in the past 4 decades, so if you see this slide, so there is a gradual increase in the trend. The upper one is OBGY, but that's clearly an outlier. So what about the Indian trends? So the census of 1961 showed that there were 5.8% of women physicians and surgeons in India, and in 71 it was 7.2%. The current ASI data suggests that there are around 10 to 12.5% female surgeons. So next, coming on to publication and authorship. The number of women authors have increased over time, but the number is still lower than men.
So this was a study which looked into the percentage of women as first authors in two journals, that is Archives of Surgery and Annals of Surgery, between 1985 and 2003. So we can see clearly the rising trend in the number of females as first authors. So what about publication and coming to publications and H index? A study, most of these are Western studies and mainly US studies. So in this study, the female faculty at the assistant and full professor rank published significantly fewer articles than men. And there was no difference at the associate professor levels. And an interesting finding was that there was a differences in year of graduation. So as your year of graduation progressed, that for example, the people who graduated in 2000 had more publications than the ones that graduated in the 90s and the 80s. And overall, coming to H indices, overall men had higher H indices than women, but not at individual ranks. So it was found that at the assistant professor level, men had higher H indices, but when it came to associate professor and professor level, it sort of evened out. So next, the gender disparity in the citation of surgical research. So this in this journal, so they found out about the disparity in citation between male and female first and last authors in 48 top surgery journals. So they found in both as females as first and last authors, they had lower citation rates. And they even adjusted to other factors like, because they found that the RCTs and the US-based studies had more citations. So even after adjustment for that, also they found this disparity, so which they commented that it could be due to some inherent gender bias. But one more thing to come out of this study was when they considered top 24 surgery, it was journals, so it was almost equal. So what about the female surgeons in the editorial board? So the one cross-sectional study from the US showed that 14.8% of editorial board members were females, 13.3% were associate editors, and 4.8% were editor-in-chief. So this study, which compared the representation of women among editors-in-chief of leading medical journals, so most of the, in the medical journals, internal medicine, so the number is somewhere between 60 to 80%. But when it comes to surgery, it's around 20%. So what about women speakers in various annual society meetings? So again, this study published in the American Journal of Surgery, the percentage of invited women speakers was between 0 to 24%, and there was a wide range basically. 7 to 55% were moderators, 7.7 to 56.7% were panelists, but what they observed was that there was a significant increase in the average percentage of female speakers, moderators, and panelists annually over time. So why is this important? Because it affects an individual's reputation and upgrades their academic portfolio. So this eventually will get them success, recognition, and then they can move on to leadership roles, and which will in turn influence the future generations. So what about the research grants? So this study, again an American study, showed that out of, even though the number, the total percentage, men were definitely, males received more grants, but when you compare the percentage of faculty and the research grants received, so 19% of academic surgery faculty were females, but 26.4% of females received grants, and most of them were first-time recipients, and most of them were for departments which this I found it very important, that most of them were from departments with female surgical chair or more than 30% female surgeons. So what is the Indian scenario? So the ASI data suggests that there are around 27,000 odd registered members, out of which 2,700 around are women, and 9 have been part of its governing council, and it had one woman president, and the Indian Journal of Surgery has had its first ever women editor in the recent times. So in this paper about GI surgery in India, published in 2021 by Dr. Sameeran Nandi and Dr. Samrat Ray, So there are around 32 MCH and 21 DNB centers with around 169 seats in India. And in this, this graph, which shows the number of candidates appearing in NEET 2020, so if you can see here, the maximum number of candidates appeared for GI surgery, followed by surgical oncology. So, but when it comes to publications, so there were only, this was a survey that was conducted. So there were only 9 institutes that had more than 50 publications, and 13 institutes which had around 10 to 49 publications, 6 institutes which had less than 10 publications, and 29 institutes had no publications or didn't answer the survey. So, but there was no, nothing about the female authors and everything. So what could be the reasons for this decreased women in academic surgery? So as we've discussed yesterday also, there is disparity between medical students and surgical residents. In US in 2019, 50.5% were medical students and only 20%, or there's a data that even says that in surgical residency, that number was only 15.5%. So we don't have much that data for Indians, but even that is on similar lines. So what could be the cause for this decrease in number? So most of these studies have come to these points that could result in decrease in number. One is general disinterest in the subject. The other one is there is this people think that surgery is a demanding field, so there can be no work-life imbalance, and there are some professional issues like discrimination, preconceived notions about women surgeons, less promotions, pay disparity could also be the cause. Absence of female mentors or role models, and public perception and stereotyping. So there was a study which actually told that the women patients, only I think less than 15% of the women patients themselves preferred women surgeons. So there is a public perception and stereotyping that exists. And so these are all the external factors. But there are, as females, there are some inherent qualities. I feel that as compared to the male colleagues, we have lack of confidence. There is some sort of inhibition, some sort of hesitation to go forward. So these also could contribute to this decrease in number or decrease in representation in academic surgery. So what is a way forward? So the number is already, I feel it's increasing. If you see the trend, the number of females in the residency, in surgical and specialty, it's gradually increasing. So family support is very important, especially in a field like surgery, wherein you work, which is very demanding, and work-life balance, it's very important. And mentorship. So mentorship is very important, especially in academic surgery, because, and I don't think it should just be a female mentor for a female. It could also be a male mentor, anyone that you can approach. And we have to be more assertive. And more women taking up leadership roles, because as it was mentioned in the previous slides, though more women in the department, so that you can get more research grants and more publications from there. And as it was suggested yesterday, role of social media is also very important, because in today's age, we need to promote ourselves, we need to put ourselves out there. No one else is going to do that for us. So social media can help us in that. So this is about leadership. So this was a quote by Dr. Jove from US. So attaining leadership is a long process. So there's a certain mandatory developmental lag while women first learn the skills of surgery, develop a body of research, and then learn how to work on a committee, to mediate, negotiate, chair a group, and finally to emerge a leader. So these women are all in the pipeline. It will just take some more time. And this is another quote that I found when I was looking for this. So at the end of it, when you are working in the surgical field, you ask, is it worth it? So this was Dr. Elizabeth from McElmore from US. So can you be a successful surgeon, parent, and spouse? So she answers that, yes, it is worth it. And yes, you can be successful in all three areas, but just not always at the same time. So So I end with two quotes, one by Marie Curie. I was taught that the way of progress is neither swift nor easy. And this is by Angelita Habergama. So there's this not taking no for an answer. Be headstrong and do not let a no defeat or define you. There is so much to learn and do that it will take a lifetime. So I thank the ISG for giving me this opportunity to present this, to speak on this topic.
Swati,
Yes, sir.
very nice you have compiled that. I have one question for you. Since you have done so much of digging in, how many women heads we have in the DNB and MCH programs in GI surgery in India?
I'm sorry, sir. I didn't look into it.
Can we, from Anu Sadaf Sindhu? Sadaf. 3. DNB programs? I mean, I would want to know that, I'm sure there are a few more which are there, which we don't know maybe because there's so many DNB. Is it on the website of DNB, the heads of departments?
Actually, I didn't go through the DNB website.
So I don't think it's there on the DNB site because I tried to look this up some years ago. Not specifically women, but names of heads of departments because we're trying to communicate with all heads of departments. But, two great surveys put up by Shruti and Ragini. My question to all of you is, why shouldn't we... so these are biased surveys. It's a very small sample. A lot of the surveys and the data that you presented here, I can pick holes in it. And say this is all biased. You're looking at a wrong denominator, you're looking at a wrong numerator, etc., etc. But if we go beyond that, why can't we design a project, apply for funding, and actually do a survey of women in medicine in India and look at all specialities, which would then tell us some of the things that we are presuming here, that surgeons or women surgeons or women in surgical gastroenterology find issues which may be prevalent in obstetrics and gynecology as well, which may be present in anesthesiology as well, or may not be. And then we could, sort of say, okay, these are the issues or these are the gaps that we need to address. At the moment, I get a feel that we're a little unsure of the actual needs and what we need to address. I'm happy for one of you to take the lead and do this. And but if you don't want to, I'm happy to write up a project and actually submit it for funding, but with some of you on it. I don't want to do it alone.
Sir, to my knowledge from last time, they've, at least when I put this survey on the last year's group, they said that IHPB has already developed a survey and it's gone for IEC. So can we start with GI surgery and
Can I ask you a small question about the same issue? Some of the questions you put up there on your survey, I realized, were the questions I faced as a young father or as a bachelor in GI surgery. Should I get married? Should I wait for my exam? My fiancée at that point in time is also in specialization. Should she also wait for some time? So I'm not entirely sure they are gender neutral questions or they are gender associated problems. They can only happen if you address the same question to both genders in the same specialty. Only then you realize some of these questions are dominant for ladies in that specialty. Some are common to all of them.
parenting is a bigger issue actually in India? Because I felt that it's not such a big issue. It
If you
is?
think, that's the question I was asking. As a young father, I had the same questions asked to myself of me.
Yes.
Should I take that call because I have a son who's waiting for me at home, or he needs to go to his creche and I need to drop him?
Yes.
Same questions.
Yes.
It's not that males don't face it. It's that females face it. Females have more dependent
We
care
can only have an
obligations.
answer when you ask the same question to both the genders and have the answers in numbers.
We should.
I feel guilty when I'm not there. My husband feels equally sad for not being there.
So all your mom's guilt were my
It's there. That guilt is there.
to each one of us. My son says,
So my only thing is, I was trying to ask whether it's the parenting or is it the gender, what they were perceiving as a bigger, difficulty that they are facing in their careers. Parenting is probably less than what they are perceiving. Again, I'm not saying this is actual bias, it's perceived.
There is one concept on which quite a number of studies have been done called the superwoman syndrome. So I was giving a talk when I went into the details of these studies. So superwoman syndrome, I think, is eating up the peace of mind of a lot of the younger generation, women, not only doctors, who want to be the best in everything, whether at home, at work, in the social circle. So if someone can actually come out of the superwoman syndrome, learn to keep a balance between everything and understand that we cannot be perfect in everything, I think the disparity between males and females in their professional life will come down. No, I was searching for that, surprisingly.
I think just because it's given a name, it doesn't happen with men. So yesterday, DNR sir's talk, he said that, again, I'm going to tell that again. Work-life balance is not like you don't have to work. You have, at every stage in life, each one of us have a priority. But again, I'm telling you, women today, like say, many people come and ask me and say, why can't I have everything? No, you can't have everything at one particular time. That we should understand and say that, okay, now I'm doing this. 5 years later, I'll do something else. That is the balance of, that is the balance which is called work-life
I completely agree with her. It's a choice you make and you are happy with the choice you have made. You make a choice that you're giving 4 extra hours to work, 4 less hours are going from your family life, and you be happy about it. Look at the positives. Maybe you are setting a better role model for your daughter when you say that you are stepping out and doing it. But it's a choice you have to make.
To speak regarding the disproportionate parental responsibility, studies have shown that even working women do about 30 hours of unpaid labor additional to what their working male counterparts do, and that is called as housework. And in parental responsibility, considering that men and women devote equal time to the parenting of the child, the quality of work in the parenting part is different. Women take the work of labor, that is everything that is required for the basic survival and conditioning of the child, while men take up the work of quality time spent with the child.
Especially with women who are educated and now they are working, the children expect the same, or at least within the family there should be the same amount of expectation. But I wouldn't say that all women. So it's a compromise that you do with your partner, that okay, you're earning more, I will do this thing more, you give this time, I will take care of this. That's what marriage or partnership is.
But we are talking not about the exceptions, we are talking to try to make it as a normalized norm. I understand if you have a very excellent setup, that is an exception.
But what you're talking is essentially the problem with society, and the change has to. A lot of talk that we have here, I feel, is what we have to change at the society level. How? So today it's our responsibility to educate our sons and daughters so that 20 years down we don't have these discussions.
So my thing is that there is change that is required at a society level. Obviously, we have to wait for the change because that change will never be immediate. But in the meantime, our job is to facilitate in places where the society will take time to catch up. That's it.
So, I just wanted to tell one anecdote regarding the mom guilt and pop guilt part. This happened like a month back. My colleague, who's a GI surgeon, the only thing he said in the OT was that during my MCH, I didn't spend as much time with my son. And the anesthetist was on the floor. She was like, I have never seen a man vocalize that they miss their son. So I think it's just about the gender roles. Like a lot of men don't mention their kids, children. They don't mention their guilt about parenting. And it's just acceptable that men don't need to be with their family. So when we promote that mom guilt part, or like that women are spending time with children, we promote it for men also. Like it has to be for both genders, but somehow in the gender roles, it's just accepted that.
Actually, this is another extreme problem of society. It's okay for me to say, I feel bad, I'm not with my daughter, I didn't see her first step. But somehow the society is not so accepting of men who say, I was not there for my baby's first word, first step. People say, be a man, go to work, who's going to win, who's going to be the breadwinner.
So yeah,
they don't even have the choice of saying all this, what we are very
patriarchy harms
happily
men as
discussing
well,
and talking.
The world is right now in a transition phase. If you see our parents and now, and I see my juniors, I see that my youngsters, the juniors are working with me, have taken almost equal responsibilities, which didn't even exist in my generation. So in the future, it may be even reversal of. We don't know, but this is a transition phase, and when there is a transition, people have problems. We have solutions at that point of time. People try to find their own solutions. People who have our parents have problems, who are not parents have problems. They also have some guilt. All these things is a part. So we are here, I think, discussing. We'll get to the next level. Please announce the speakers.
May I now request our next speaker, Dr. Sharvari Pujari, ma'am, to come on the stage, please.
Good morning, seniors and colleagues. I would be presenting on women as leader authors in GI surgery publications, current status, and how to improve. Some of the silent aspects are already covered by Dr. Swati, but I would like to concentrate more on GI surgery, starting from the general surgery perspective. So, quoting the same paper, publication is considered as a benchmark of academic success. And starting with the same paper which Dr. Swati quoted, this is a paper published way back in 2005, which looked at the status of women authors in surgical research. And from randomly selected issues of Annals and Archives of Surgery, they reported that there is increase in overall number of female authorship, statistically significant, especially in archives of surgery. However, this percentage of women authors is a small fraction of all the authors, and proportion of the first authors is still small compared to men. Over the years, we have discussed since yesterday that more and more females are opting for medicine and so also for surgery. However, this data, American data in 2017 has reported less than 1/4 of faculties of surgical specialties are female. Thus, women are underrepresented at higher positions and leadership roles. So this higher proportion of younger females coming into the field of general surgery has subsequently reflected as far as the authorship is considered. And this paper, which shows trend in female authorship, this is a paper from with a large data, 19 high impact journals they have chosen. Although the journals included breast surgery and trauma surgery and surgical pathology also, but from more than 71,000 articles, they report that there is an increase in female authorship, but majoritarily it is about the first authors than the senior authors. Thus, the glass ceiling or the sticky floor effect is there today also. Women are seen to publish less frequently in less impact journals, And this paper from US and also other papers have given that this can be one of the reasons that females are getting less promoted to higher positions. So there is persistent gender disparity at higher academic levels. And as you can see here, majority of the department chairs, that is 85% chairs as we just discussed, are occupied by men. So after 20 years after that initial paper which I quoted, today also the situation is almost same. The overall female authorship has increased, but still it is less than 20%, with fewest further low proportion as a corresponding author or last author. And this is not only representative data of US and UK, but the problem is worldwide. It is quoted from Japanese academic surgery, from German university, from Italian literature, from Chinese literature, across all the specialties like gastroenterology, hepatology. Cochrane review also represents same, and thus it is reflected as a global gender problem in the 2020 Global Gender Gap Index in the peer-reviewed surgical literature data is considered. Now coming to focusing down to my topic of publications by women GI surgeons. As we know the GI surgeries, I will consider it as under various specialties. So starting with the HPB, the status of gender disparity in the number of women in is more profound in HPB faculty of GI surgery. Only 16% of the US HPBA members were women in 2019. And if we consider the members according to the age group, the 2021 data shows that among the under 40 years, 28% are women. However, in the 40 to 50 age group, 15% are women, and above 60 years, only 6% are women HPB surgeons. So subsequently, this reflects as far as the authorship in HPB journals is considered, and this paper has looked at it. It is published by a female author, and they have looked at 7 journals, article pertaining to HPB surgery from Annals, BJS, JAMA, Annals of Surgical Oncology, HPB, Oxford, and Journal of GI Surgery. More than 1,400 articles. 28% articles had at least one female, one of the authors as female. However, when senior authorship was considered, the proportion was only 1 in 10. A similar paper actually published 2 years later than the previous paper by Sela et al. And again, 5 journals they have included. 4 of them are similar to the previous, but they have analyzed it more critically, and they show that there is male preponderance in all authorships, as well as in first author and senior authors, male predominate. But there is rising trend in both female first and senior authors over years. Coming to colorectal surgery, this is the data from 4 journals of colorectal surgery, diseases of colon and rectum, and techniques in coloproctology. 4 significant journals of colorectal surgery have shown a slow but steady growth in overall female authorship in all authors, but there is significant difference as far as first author and last authorship is considered, and all article types also they have analyzed, and there is growth. But they report that India is in one of the 5 countries with least authorship, least female authorship in colorectal surgeries. For this presentation, I thought, let me look into the literature, what is the status of women in our this and publication status. So I chose diseases of colon and rectum because I thought this will have large number of female authorship. This is a century-year-old journal. The journal was established in 1899, and in the history, the journal reports that in 1997, that is after 100 years after the first issue of the journal, they report first woman as a program convener. And now the editor-in-chief in this journal is a female surgeon. And what I chose only 2 issues. There were a lot of number of articles, and for each article, I looked at each author. If there was a clear-cut indication by name like Rosie and Susan, then it was a female. When it was not, I went back and checked on net whether it is a male or female author. I came across 68 articles, and to my surprise, in every alternate article published, there was at least one female author in the list of authors. So the proportion was 34%. However, out of them, majority were 18 were of first authors, but only in 2 papers, last author was a female surgeon. Coming to surgical oncology, this data from the surgical oncology meeting shows in sessions like poster presentation and panel discussions, the equal opportunity, almost equal opportunity is there for female surgeons. However, when it comes to prestigious sessions like plenary sessions and video presentations, even senior authors of senior female authors don't get that much opportunity. And they have also looked at the relation of first and last author being male and female. Similar results were reported from minimal access surgery and bariatric surgery also. Now coming to the glamorous branch of transplant surgery, we know that even in the smaller period of liver transplant, there has been a significant contribution by female transplant surgeons. The Nancy Hatcher's name was quoted multiple times since yesterday, but overall, women transplant surgeons are only 18% of all transplant surgeons, but hepatologists are also not great. Only 31% of hepatologists total are females. So also it reflects in the transplant authorship, as this paper from 5 transplant journals shows that there is very less representation by women authors. Now, what are the possible explanations for that? As I said, there is the sheer number is less, low percentage of women in that particular field of specialty. Further loss in number as at a higher positions due to various reasons. In addition to this, these greater domestic responsibilities leading to less time being a female can devote to research and pursue research. These are the known factors. Few publications report that the females are less likely to be sought out as research collaborators by others, and they are less likely to get funding from the funding agencies. This Brazilian paper, when they came across similar results, they reasoned it out, and they suggested there can be a Matilda effect where there is inherent or unconscious bias against women's credibility or achievements, which tend to be contributed to male colleagues, and there can be a leaky pipeline effect as the women tend to get dropped out of their career advancement pathways due to various reasons we discussed. And they suggest a mentorship can be a solution for this. So mentorship, next talk is there, but it is proven to be crucial and beneficial for both personal and professional development in surgery, leading to increase in confidence, reducing burnout. So along with organizational support, these 2 factors become most important factors influencing women's career or in surgery, and lack of that can lead to imposter syndrome. Going further ahead, importance of same-sex mentorship is quoted by this Fawcett et al., and this paper is quoted by various mentorship articles frequently quoted, and they suggest that it is seen that when woman is the last author, there are high odds having woman as a first author also, and women in senior positions are aware of the responsibility to contribute the growth of others. But it is not that we always can expect something from others. We have to pursue, we have to put in the efforts on our own and pursue the research and publication. There is a quote in Bhagavad Gita that Uddharet Atman Atmanam, means it is the individual is responsible for himself or herself growth and progress. So it is suggested that we should promote our own success, or we should pursue the publication, we should expand our friendships and have more research collaborators, and along with this we should inspire, encourage others also, and help others and admire them. But having said this, we have sent an article for publication. Can there be something like that, something like gatekeepers of scientific publishing? Yes, because it is seen that women as editors-in-chief have higher rates of publication by women first authors. and women on editorial boards tends to invite more women as reviewers. So, this paper also has looked at the same, and from 25 surgical journals, they have looked at the editorial board, and they report that only 20% of the total editorial board positions are occupied by women, and editor-in-chief are as less as 10 to 11%. So a diversification of editorial board can be one of the solutions, because women in the editorial board can consider changing the review process of the articles and eliminating the possible conscious or unconscious bias against the gender. But the times are changing, and people are becoming aware of that, and various journals are now accepting and they are promoting female authorships in various journals like Gastroenterology, like Digestive Disease and Sciences Journal. They are committed to diversity and inclusion of females in the editorial boards, and World Journal of Surgery has announced as one female surgeon as one of the associate editors for the liver surgery section. In the conferences also, this is getting reflected as more and more chance is being given to female speakers, and this SAGES data has shown that when there is a woman convener, higher number of women speakers are likely to be there in the conference. So including women conveners can be a successful strategy to improve the gender balance. And this has reflected in their SAGES annual meetings, and they have demonstrated a positive increase in the representation of women surgeons in the all the first authors and oral presentations. Also significant rise in that after 2018, when they started that initiative. And this present meeting at our society, our IASG and the institutes like AIMS and AIG are conducting this meeting. They are the initiators to conduct this meeting. That is the biggest proof that the changes are there, and in fact we should thank them for helping us, and they are thinking of our progression and growth. So there is a change, there is light at the end of the tunnel. However, it is projected by the Society of Surgery of Alimentary Tract that if all these things are done and pursued, then it will be not before 2044 the gender parity is likely to be reached in participation of women in academic surgery. Thus, to conclude, gender disparity exists in the publication of GI surgery. There is rising trend seen in overall female authorship. But this rise is especially as a first author and as a last author or lead author, women are underrepresented. Reasons can be multifactorial, but individual, institutional, and organizational contributions will lead to achieve the gender parity in coming years. Thank you.
Enjoyed your talk, Dr. Pujari, but just a couple of questions can I ask? One was that since you done an extensive analysis of the authorship, the proportion of the authorships which you mentioned, was it lesser than the proportion of women surgeons working at that time in that specialty in that area? Was that the way it was analyzed, or just by versus men in that same specialty? Because that will not work. The number of women working have to be proportional to the number of authorship in articles.
Yes, so since that's why I compared 2005 with 2024 papers. In 2005 also the authorship percentage, overall authorship percentage was in the range of 20% to 25% in annals and archives. After in 24 also the percentage almost remains the same in spite of increase in number of females in medicine, but it may not be that proportion in surgery and may not be in the authorship.
I get the point. Last bit is a comment or maybe a question. I understand that most good journals, the review process is masked. The title page is not available, the names, institutions, gender especially are not available. So how does that translate into changing into gender neutral editorial process? I'm not entirely sure what you mean by that.
maybe if the gender and the authors are kept, I mean they are hidden and the review is done, then it should not matter.
Yeah,
If it is revealed and if there is some bias against the females,
Yeah, I
then
had the same question because when you send a paper, actually the paper is completely masked actually. So I don't think this is.
But sir,
You should
the
answer.
editor has the details, and the
So,
decision is
so
taken.
gender is not mentioned anywhere. The name, from the name, you could try and figure
Yes.
out whether a person is a man or a woman. But the names may be available. So, Indian journals generally tend to do what is called a double-blinded peer review, where the author doesn't know the reviewer and the reviewer doesn't know the author. But most good journals, for example, the Lancet, the New England Journal of Medicine, the BMJ, all these, the top-notch journals, don't follow a blinded system of peer review. Randomized trials have shown that the blinded system of peer review doesn't improve the quality of reviews, increases the expense, and increases the logistics and the effort that one needs to put into it. So that's beside the point. Gender is something that you can't make out unless you specifically, and the very few reviewers who would do that, to the best of my knowledge. Just a small piece of information. A lot of these, as I said before, you don't know the denominators, and you're talking about numerators, and therefore there is this perception that there is a bias, which may not necessarily be true. I take you back to two pieces of information that I have. In 1988, the British Medical Journal and a team from the British Medical Journal came to the Indian Institute of Medical Sciences. I was a resident at that time. And they did a session there for very well attended. I don't know if somebody remembers it. Were you there? 88? So I don't know if he remembers it. But one of the questions asked to the then editor of the BMJ was, Dr. Stephen Locke, was, why are you biased against Indian authors? And he said, number one, we don't receive as many submissions. Number two, we bend over backwards to accept, because we want a diverse audience and a diverse authorship. We want people to know that we are an international journal. We are not a BMJ. We are not a British journal. So we bend over backwards to do it. So this was news to us, that they weren't receiving submissions. And, sometimes we just perceive something and we believe that that is true. So this is one example. The second piece of information is something which in 2007, I was invited to sit on a committee of a small group of international medical journal editors. I said, I'm a surgeon, I'm going to sit there. These are all general medical journals. There are 14 of them. Very unlikely there'll be any other surgeon. This was my perception. I went there and I found that 6 of the 14 were surgeons. And interestingly, 7 of the 14 were women. And this is 2007, when diversity, equity, and all these words wasn't sort of common parlance as it is today. So sometimes our perceptions are not right. So there may be, if I was to say how many editors-in-chief, I'd look at the number of editors-in-chief applications from women, and then see whether there's a disproportionate number who were not chosen. So then if the number of applicants, if you were to do a survey of the executive council members of all the surgical associations in India, and you'd see that the representation of women is very few. But then you need to look at not the number of women in those associations, but of the number of women applicants for those positions before you can actually say that there's a bias. So I'm not saying this data is wrong. I'm not saying that these perceptions are wrong. All that I'm saying is that we need to get better data.
Can I just...
Sorry, sir. Go ahead, sir, please.
No, I just want to add to this. You made one statement that the citation is less. I mean, I wonder who looks at author details to quote an article or cite an article. And oftentimes, you can't make out the gender from the names. H. Ramesh mistook my authorship as a female surgeon writing an article, and he started searching who's this one. So I don't know whether there's just an exaggerated form of saying that.
No, sir. About citation, I did not
You mentioned
analyze
that one
in
place.
terms of citation. I think that was it.
You mentioned. Okay.
And for the reasons, I again and again stress that we are at the fault more than 50% of times. Not at the fault, but our numbers are less. Higher positions are less. Domestic responsibilities are there. All these things are there, and these are well-known factors. But in addition to this, we can maybe 2-3 more factors can be there. So first of all, we have to start publishing, we have to pursue research, and then other things will come. I also completely agree with that.
I agree with what sir said, because I review papers, but we never look at the authors, whoever it is, whether a man, woman. We don't look at the author. We say what is good in the paper to say whether it can be acceptable or not. And I think everybody, when that position is given, you are looking at that particular, because you want to be the best reviewer, not like, okay, I want to give it to Ragini or I want to give it to you. It's not like that. But like say collaboration, yes, I feel that when it comes to collaboration, especially the multicentric studies and all which are being done, there may be a little bit bias, because again we are not networking. We are not able to network to that extent of collaborating papers, studies worldwide. I see many of my colleagues who are so good at it. I mean, they are really good. I appreciate
So,
that they are doing it.
we can conclude that the difference of numbers is there in editorial, as far as editorial boards are
Yes,
considered.
it is there.
The difference is there, but whether it is the reason of less publication, we can blame on that, we don't know. And it may not be the reason, but on the editorial boards, the significant difference is there.
Like, see, we need to look at the denominators, like sir said. Can we go to the next?
Thank you.
Ma'am, just stay back. I request Surgery ma'am to present certificates to our chairpersons. Dr. Swapnali. Dr. Manasa. Dr. Shraddha Patkar.
With this, we move on to our next session, which is Leadership Policies and Finance. And I would like to call upon stage the chairpersons for this session, Dr. Mahesh Shetty, Dr. Sonam Mathur, and Dr. Shraddha Ramchandani. Our first speaker is Dr. Vibha Verma.
Chairpersons का नहीं बुला.
Good morning, everyone. So most of the talk which I am going to deliver has been covered in part. And I can't start a talk without a mention of Dr. Nandi, who has been my mentor. And I think I owe a lot to my mentor. He's one of my mentor who is, I think, one of the key mentors in my path. So the talk will be on mentorship for women surgeons, the definition, the importance, whether it is gender specific, and how you can support a career development and advancement of women in GI surgery, how to overcome the barriers, networking, and importance of leadership training. So one thing which I want to make it clear, that women should not get scared about what you love to do, and you should go out and do it. There should be diversity, equity, and inclusion in any setup, and I think people have realized it, and we can't complain, but a lot has to be from within. And for that, you need a guide, a mentor, advisor, a role model. And we know that women constitute a small proportion of surgical residents, faculty, and this is despite the growth which is occurring in mentorship opportunities, though not in a formal way in our country. it is very formal in US and UK. But I think in our country, we know what is mentorship in a different manner. We look upon our teachers and colleagues. And during internship, while doing your surgical rotation, that is the time you develop your interest in surgical fraternity. And there, if you have a woman in surgery, a successful woman in surgery, they become your role models. And even if you don't have females, some surgeon will become your role model and you get interested, and it need not be gender specific. So I also did a survey that was within our group of GI surgeons, but it was also within our MBBS batchmates. And I got about 80 response, so I'm lucky. Actually, I got a lot of response. This was going on till 3 days back. And thank you for that. So it's important, how important it is to have a mentor in the career. Almost 90% agree that you need a mentor. And do you think that same gender mentor is important? It is not true. More than about 50% thought that you don't need a gender specific mentor. Only 20% thought that they should be gender specific. So the mentor can be anyone. It can be, you can call them a mentor, coach, preceptor, teacher, supervisor, appraiser. They are not synonymous, but they are required at different times in your life. And this is not my quote, but someone says that when you go to the theater and you see a peristalsis, you get so enamored by that that you know you want to take this branch. And the specialty which you have to take, then your mind gets clouded when you are a female because of the work-life balance, being a woman, the lifestyle which you have to take on. And some of the males or people in the fraternity telling that you can do anything besides surgery. But then it is up to you. You have to see your passion, that whether in the night you want to take a call which is of your interest, or you want to be woken up at 2 a.m. on a Saturday for a call which is your passion. And there comes the role of mentoring, and it starts in our early days. We identify a person, he or she may not be actually mentoring you, but you start emulating them. And it can be in the form of the goal you want to achieve. It can start as a guidance, it can be your teacher training, it can be a motivation, a support system, and that ultimately leads to your success. So all females, I gave that icon because I really love it. It's lift as we rise. And that is something which all of us should try and do, whether we are junior or senior. So mentorship is a powerful tool. It has a critical role in the rise of women in surgery. And it can be one-to-one with an expert or a senior who voluntarily gives time to teach, support, and encourage the other person. And they serve as career models and role models. They need not be gender specific. But it is found that females, they make a choice of surgical career when they see more percentage of females in the same specialty, and they get more satisfaction about their own career in that particular specialty. So mentoring is important for guiding an individual, and the mentor should be available, an experienced person who has that empathetic approach, and they share their own ideas, learning, personal and professional development. And the mentor often gets a personal satisfaction by doing this. So the key principles of mentoring are that it should be freely entered into. It should not be coerced. It can be a confidential matter between a mentor and a mentee. And there should be boundaries of relationship. You don't have to enforce your views on the mentee. You can discuss out. And how often you discuss, all these are actually very much defined in UK and US, but I don't think you need to have so much of clarity as long as you are taking help from the mentor. So the reasons for dissatisfaction at work is because as females, I'm not telling about the gender, this is gender neutral statement basically. The lack of credit and support one receives in the OR or in your specialty, and women have lesser opportunities, they have limited access because of the sheer less number which we have. And we also suffer from imposter syndrome, where you start doubting your own intellect and skills. And this can be seen in people at senior levels. So whether women should be mentoring women is a question, but I think there is a formal mentoring guide which is there on the Royal College of Surgeons website, where people can actually go on and say that you need a mentor, you enter into a program, and there's a well chalked out program of 6 months. There is a form which a mentor or a mentee can fill up and enter into such a program. I put this up because for our juniors to understand that if you go and do networking, there is a lot which is available. And it is especially for those who are underrepresented, and I feel females are, and it helps in their representation and career development. So there is this study where they have done a very small study where they have included the residents, the medical students, and the younger faculty, where how they have studied the access to mentorship, what are the characters they value in the mentor, the role of gender identity while choosing a mentor, the racial identity, early access to mentorship. And they found that if they are approachable, they have time for their mentees, they are honest and available, they need not have a gender specificity, and if it is given early on, it really helps. Women do look upon women as female mentors, but that is not the case, as the survey says. And even a male mentor can be equally important and considerate toward female mentees. And this is my personal experience, and I feel that many of our teachers, they are not females, and they are worried for you, and you can reach out to them. I think many a times the problem lies with us. We don't reach out. So the challenges which has already been discussed, so I found that they have mentioned and they have done this survey where female surgeons have actually delayed pregnancy because of residency about 70% of the time. And in today's date and time, there is the concept of oocyte preservation, and they don't want to take up pregnancy during residency, which I feel is too much. And I think there has to be something done for this. And but of course, it depends on the individual. And we need to have some honest discussion on this so that the career and personal goals of women are reached and we benefit our female mentees. So it is seen that whether the male or a female mentor, it does not matter. And females have also quoted that if they were really looking for female mentors, they would not have achieved what they have. So there is the lack of female mentors, and finding it is difficult. So I think we have to find out a person whom you identify yourself with and with the qualities which you are looking for in a mentor. And the certain issues like feeling of exclusion, quality of life, the salary issues, poor accommodation during childbearing years, and your tenure. Then there is a queen bee syndrome, which I think all females, we should understand that when you achieve a senior position and you are a female, you have yourself suffered. I think it is time that you help your own female fraternity. But this syndrome is there because everyone is aware of it. I think we have to overcome this. So by teaching, we learn, we all know this statement. And I think I believe in it, that when you teach a person, you learn more. And I think we have to take on that as a career challenge. Contract negotiations, we are not good at it. I mean, I'm not good at career negotiation or my job propositions. I'm not good. I can only tell that I'm skillful, I'm senior, I'm experienced. But you have to know much more than your skill levels. So a small leg up during a career and giving them better opportunities, better leadership positions is what one looks for. So this figure has been quoted before, that 50% of women are in the medical school, 30% they take up general surgery, less than 10% they achieve full professorship, and even after working up, it has reached only 9.8%, and to even out, it says that it will take 90 years. So do we have to wait that much? So leaking pipelines are actually sorting out processes where females are sorted out and they are underrepresented. So I think we need to stop this sorting process, and here comes the role of mentorship. So mentor is required for all. It's not for females or males. They have a positive influence on everybody's career and life. The focus on women surgeons for the challenges which they face and the difficulty in finding a female mentor if they really want a female mentor. And negotiations in the job, as I have mentioned. And we should be concerned about the sexual harassment, about the insult as a gender, and the concerns and repercussions which a female faces about speaking out certain things. So for every surgeon, the requirement of the mentor is different at their different career levels. Initially, you want a teacher. Later on, you want sponsors. So basically, you want to have job opportunities. You want someone to give you more leadership roles. So mentorship actually ensures that there is diversity and inclusivity, and better working environments are given to people who are underrepresented, and ultimately it also translates to better patient care. And for the mentor, of course, it is rewarding and satisfying to see that the mentee reaches a good position in their career. So as I mentioned, it could be a coach or a mentor or a sponsor at different times. I am not skipping this because there's... So as we progress in your career, a person who was a mentee becomes a mentor. So peer mentorship is your own colleagues who are good at certain fields or certain branches. You can make them your mentor. Or there is a reverse mentorship. Now robotics and laparoscopic is coming up. There was a time only open surgery was there. So your juniors can be your mentors. In robotic surgery, I actually look upon my juniors because I sit with them and I want to learn from them. So there's no harm in having a reverse mentorship. And of course, the benefits are for all. So the other question which I have mentioned in my survey was, what obstacles do women face in achieving success? So most of them, they replied about a combination which included the workload. That was very little, but inequality in remuneration, gender bias in assessing the efficiency and stereotype, and workplace bullying. How do you overcome the barriers? 40% of the people, they felt that you just do your bit and the success should follow. I think I follow that. And some people, they have to 10%, they have to work harder. 30% have to prove their efficiency every now and then, and 20% believe in networking. Do you believe in networking? About 75% agreed that networking does help. And what are the ways of networking? I think it's a combination. The web page, WhatsApp, webinars, and LinkedIn, Facebook, whatever suits you. And I think visibility and making people aware that you are available is important. And reaching out to people whom you can learn from is important. So in who helped you in your surgical career? This was the other question, which was like, I received varied responses. I have combined, but most of them, they got help from their teacher, unit chief. Some of them had parents as their people who were behind their career success. And female teacher, female colleague was actually very little. So it's not important that you should have a same gender mentor. The next question, what are the strategies for career development of female surgeons? I think the first few are, any surgeon would like to work hard, develop their skills, be sincere and up to date. The other things like female surgeon model, and deaf ears to opposite gender comments, I think these are all strategies where you have to push yourself. This was one comment which I received and I wanted to show it up, that I don't think there are special strategies for women. And also to call ourselves as women in GI surgery, the work we do requires a lot of effort and patience. Anyone who has that can be successful irrespective of gender. And I think calling ourselves female surgeons is somewhat discriminatory, and we are surgeons and get the job done, and gender bias is there everywhere. I think it is very true, and we all sound this, but as a female, we need to voice our concerns. So the thoughts about expectations from the mentor, I think all the qualities which a mentor should have, a female need not be there, but a role model, and they should have someone to have a balance between life and academic career, someone who can counsel them, gives time, research skills, knowledgeable, well-respected, and they are approachable, trustworthy. I'll skip this. And I think many people agreed that they need a training in leadership qualities. And I think this is something which everyone is looking upon, and we could have a session from ISG or individuals. And how to become an effective leader, you need all the qualities. And the benefit of mentoring, it translates to not only mentor and mentee, it translates into better patient care, and the institute also benefits because there's better communication skill, better performance, better retention of good people. So sponsorship, I mentioned that apart from mentorship, you need sponsorship, which helps in your advanced career and promotion. And in one person should be advocating for another individual who is a junior and who needs support mechanism, so that scholarship and grants can be given for training in career development, opportunities to acquire new skills, travel to centers. All this requires a push. And courses for leadership quality, courses like contract negotiation, salary benchmarks, promotion process. I know these are not taught in our books, but I think we need to know this and acquire the skills. And we know that women are paid about 30% less than their male counterparts. And in most of the, I'm not talking about public sectors, in private sectors, people who are doing good work and being females, you are at a loss. So the glass ceiling effect people have touched upon. Here, again, the mentorship helps so that you can support your younger surgeons, identify the worthy women leaders, pushing the young women surgeons and providing them with opportunities. I think I'll skip. So one thing which I received a phone call and I was told that I should include this in my talk. And I thought that we've been talking about a lot of things which we don't discuss, and this is one of them. A female surgeon standing for 6 to 10 hours and has a periods. We don't discuss this in OT, but people have suffered because of this. I think as male counterparts or senior female colleagues, we should be taking care of this. So someone puts up that you are a first assistant, there is a 10-hour surgery, your job is to do the surgery, someone has given you an opportunity, but there is a problem and you need to take a break. Now, who considers this? And when you return, whether you are going to get that opportunity or not. I know no one is going to help, but I feel that this is an awareness which one should create in the OT, and maybe someone should go out and help and maybe speak up. So what was told by the person who called up is that they feel bad that during a time like that, if they need a break or off half day, they are not given, but a male counterpart says he has to drop his child or go to a gym and they are given a break. So I think that is not fair, but I'm sure it doesn't happen everywhere. So women as leaders, where are we? So you have to overcome the obstacles in your path, push yourself forward with resolve and faith, position yourself best. And this is to reap the rewards and the efforts which you have put in to become a surgeon which you are. And it is an observation that great surgeons become great surgeons not because of themselves. It is because, and it is not accidental. It is because they are surrounded by great surgeons. And it is their duty to be in a situation or reach out to people who are innovators and risk takers so that they can help them out. So I am finishing. So networking benefits. So we have a lot of conferences and association of women surgeons. People who are interested, they can reach out, they can attend, and I think it makes a difference. And these are my last few slides, that sometimes people whom you think they are not approachable, they are the most approachable ones. I can say that Dr. Nandi, if you go on a Sunday, for me, he will spend 2 hours. just to listen to you. I'm becoming emotional, sorry, but I feel that you need that kind of person. Thank you.
Thank you.
So this was a collaboration. I wanted to emphasize that we have started the work. I think we have, in the last couple of years, come up and we have put in our efforts. I think it has to go forward, and I think we have to play the role. As females, we don't need IASG, we need our own efforts.
Doctor, I have hello. Doctor, I have two questions for you. First of all, I'm a gynecologist. The obstetrics is a fully female-dominated field, but not gynecology. Especially the minimally invasive gynecology is still dominated by male surgeons only. So to promote ourselves, we have few international platforms like World Endometriosis Society and all. We have there we have specifically the mentor-mentee program, so that we can choose our mentors on an international basis, the online platform. So do you have anything similar in the GI surgery also?
So as I mentioned, there is something in Royal College of Surgeons. There is a platform where you can apply, but whether it is for everyone, whether you have... Yeah, so I went on that platform. They have upcoming program. But I don't think you have to be probably GMC registered. You can't probably apply straight away from other countries. But there are meetings which you can attend and maybe find avenues. And I would say within our country, we have enough people who are seniors and they are approachable. They are good. So telling that you don't have people to make your mentors, your own colleagues, your seniors, your teachers, your friends, they can be your mentors for several things
Yeah, definitely, they can be there.
And what you're telling as a platform, even for skill development, you have many of us have gone out and reached out. They don't need anything. You just have to call up, maybe spend time and spend money. So there comes the role of some sponsorship and grants. Not everyone can afford and go out.
Yeah, that is the main issue.
Yeah. So I think there the societies can help.
I think we'll end the session and we'll go to the next speaker because we are really running short. Okay, Dr. Mahesh, one quick question, please.
Yeah. Great talk, ma'am. The concept of gender neutrality in mentor-mentee relationship is very true. You being my mentor, I still remember the days I used to come to NIMS for classes, and then she was the only female and we were all men as students there. Thank you. Nice talk.
Thank you, sir. We'll go to the next speaker.
I'd like to invite Dr. Gomti on stage.
Hi. So, I'll give you the overview of my talk. Little bit of talking, more of putting all what we kind of grasped over the last almost 24 hours now. So I'll probably give you an overview for about 5 minutes, or less than that, and then we'll split you into groups. Right now we can, if you don't mind, group into this side and that side. One side being, let's say, people who are into surgical training for the last 5 years maybe, and on this side, those over 5 years. Can we please? Less than 5 years? Over 5 years. Including training, super specialty, yeah, your GI training. But there are too many numbers, I'm going to change things around. It's not based on age, Sumana, so you can comfortably switch it. No, this is, let's say, trainees and early career people. This is like, Gayatri, how many years are you? No, I just want to have a balance. So if it's 7 years, I would, work differently. Can we have all of you, please? Yeah, Sadaf would come this side.
More than 5 is there.
Less than 5 years. They're all early career. So if there are too many here, I'm going to make it 7 years. 7, yeah. Let's say 7 years here because I see more numbers there. Yeah, great. Okay, perfect. Even among this, later we would be splitting you into 2, like 4 and 4 of you and 4. Right, okay. All right. Yes. No, we'll get together later to have some chat. Yeah. So no, this is beyond 5, but I think we can do the 20, 25, 30. The women, so we can have on input. Talk for 4 or 5 minutes, and you will take over and speak. I'll come back later with the inputs given by you. Right? This is okay? Yeah, sure. So, all the positives. We're increasing in numbers. There is improving awareness on the need for sensitization. Like all of us discussed, we were not talking about this few years ago. Let's take a parallel from the LGBTQ community. People were worried to even talk about them, even address that concept, even 5 years ago, 10 years ago. Now, if you don't address or if you discriminate them, you're in trouble. So it needed voice. It needed a strong voice over a period of time to get over that or even get sensitive about it. So we need to work towards improving awareness and sensitization. Moving up the ladder, leadership positions, we need to give it thought. Start giving it thought. It takes time for everybody, for us also. And influencing the decision makers needs a strong voice. So a lot of what we spoke about are big ideas. To make those big ideas, we need to start from small steps, incremental steps to get there. Now, I'm going to just quote from parallel industries, not from our own. This is from the Kennedy Space Center. This is about their journey over the years, and it talks about how it's a man's world, the NASA. And the table of contents, I found it very interesting. So they go back to 1962. Many, many years of work has gone on, right? And this is about women in NASA. So the first year's representation, token representation, how the movement works, and then working women becoming the norm at NASA. And then equal employment opportunities, 1990 to present. But what was interesting, actually, I would recommend all of you to read this. Room for improvement. There is so much that's being spoken about, all of what we spoke. Nothing different from what we spoke. I'm sorry, last minute when you do preparations, you kind of, something runs out, your snapshot didn't work, so I had to take picture and put it in. But basically, this last sentence, as Anne, I don't know who she is, she's somebody important in NASA, the more women there are at KSC, Kennedy Space Center, the greater the acceptance. Hopefully, this change in behavior, as it did during World War II, will lead to permanent change and acceptance. We need to work towards that if we want to make any change. I've quoted this in our last meeting. I really admire her, and this book is fantastic because she goes on to say she got it done with her family support, with her husband's support, but at the same time acknowledges not everybody has it. So she kind of puts out things which other people need, not because she had it tough. She had it tough in different ways, but to address what women need. So there are 2 or 3 things. I'm just putting this as an overview for your thoughts when you get together as groups. She's top up in the ladder. And then she gets criticized even towards the end of her CEO, that term. Every time a person of color or a woman gets hired somewhere or does not perform well, they would say, oh, this is probably Indra's quota hire, or it's somebody related to her. After so many years of proving that she was the best CEO, not just a woman CEO, she had to face that. So remember, as we go to leadership positions, this queen bee phenomenon that Vibha spoke about is all related to this worry that sometimes you would be labeled this. So that also is an influence when we make decisions. And actually, when she retired, New York Times very boldly said, when a female CEO retires, the glass ceiling comes back. So all what she did, it just is individualized. Okay, it's only her. It's not going to happen again. So these are some things which we, always have to remember. And that picture was actually a very large one. Of the three of us, me, Utpala, and Sadhana, the three of us surgeons in our team operating. So it was days when I was alone for a very long time, but things are just changing. I'm sure it's changing for all of you. So it's just waiting to happen. Let's see what we can do. Keep this as your framework. When we say workplace culture, we're going to change it. What are we going to do? Surgery was framed as a man's world. We all know that. Only now we are entering. So whatever is existing was thought of as a man's world. Let's now just step back. Think at it as a all women's field. Okay? What is it that we as women would want from it, from workspace culture? Let's put down our thoughts as a whole women field and see what we can achieve. But please remember, you need to keep this as the framework for workspace culture. We cannot run away from this, whether it's man, woman, anybody. So we need to remember respect and trust, cleared and shared vision. Each of us cannot think differently in the unit. Employee empowerment, work-life balance, recognition, appreciation, opportunities for growth, teamwork, collaboration, transparency, inclusivity, diversity. Remember, it's all women team, so there'll be a one man there. Please remember him when you put your thoughts together. Low conflict, high feedback, positive leadership, social connection. Keep this as the framework. We'll be splitting you into, when I meant staff level, I meant trainees, which would be this end. You will be two groups. One group would be putting your thoughts, how to improve the workspace based on your expectation from your leaders, say the first four of you. From Gayatri to the next four, you would be the trainees or the junior level who will think about expectation from your colleagues to make it a good working environment. Similarly, on the leadership team, maybe till Ragini, would be expectations from your co-leaders. And the next group would be expectation from your juniors to make it a good working environment. I'll leave you some sheets. Take 7 minutes from now, and then I'll collect the sheets. I'll come back to you later with. Is that okay? So expectation. Leaders. Your junior college. Ragini. Okay, bye.
Expectation is have a junior.
We are not going to stop the session. Jenny, please announce.
Ma'am, can I ask you to come on stage to hand over the certificates to our
No,
chairperson?
are you done? So are you done with it?
You guys have to discuss.
Or we have to discuss?
Yeah.
So is it part of our 15 minutes?
Yeah, correct. It is part.
Yeah.
Don't worry, I'm going to talk more in that.
No. We just want to clear certain things.
We have, I think, 5 minutes. 5 minutes, and then I'll take it. So I think the next just generally,
Dr. Somna. Okay. Rajni sir, so I have one question for you. So does IASG has any special programs for female
GI surgeons which are particularly dedicated for female surgeons, whether it is about surgical skills or ancillary skills? So, ma'am, myself, Dr. Sonam Mathur, I'm a medical gastro consultant, and I've been part of lot of mentorship programs in medical gastro field. So, I was curious to know. I went through the IASG website, and I asked few of my surgical gastro colleagues also. So, my husband is also a surgical gastro consultant. So I want to ask, is there any program which is specifically for females? One thing, whether it is about surgical skills or ancillary skills like administration, leadership, or like how to workplace, how to handle the situation, publication, those things, one. And second, and other than that, gender neutral, any other programs are there for the young surgeons?
Can I start? Right. So the longish question. Short answer is no, we don't. The long answer is that we decided our emphasis and priorities lay with the training of young surgeons, whether trainees or young consultants or GI surgeons in smallish towns who don't have that much support systems. That was what IASG's primary priorities have been over the last, say, 15, 20 years. And of course, imparting newer skills as they arose, ultrasound, skill courses, whatever. This initiative which you are referring to now refers to essentially gender-specific support. So the short answer still remains, do we have one now? No. Do we want to have one? Yes. And that's what the last 2 years have been kind of movement forward in. And so this effort that you're seeing today is a kind of a milestone in the last 2 years. What will come out of it? Well, I can't be very specific about it. What are the expectations? That's what we want to draw out. That's what I think Dr. Gomti wants to put out here. What are the expectations? And we've been through this in the yesterday's, you were with us yesterday in open house. IASG's expectations from you or our colleagues here, ladies, is to give us actionable points. So again, last bit, short answer, no. We want to move forward, hence these meetings, and hence, unfortunately, it may sound very simplistic. What are the actionable points? 2 years, we still don't have them. So I agree, it is a process. So you can't weigh these things in these lights. But we have movement forward. We moved forward from the first objective of IASG, which was training our membership, especially the younger people. Move forward significantly in those. So you've seen, actually, if you go to the website, you see those options. The CMEs, the skill courses that we conduct, the PG clinics, they are all in that direction. And those have been going on for almost 10 years now, 15 years now. This we've just started. So you can't expect the same growth in this aspect as we have in those aspects. But we will have growth, that is for sure.
So my few suggestion is that you should also have programs for junior consultant so they can progress to their next level of senior consultancy and all those things. Rather than only focusing on the residents, it should be also focused on junior consultants.
So you're right, we don't have one which is specially named as such, but there are several programs which enable you to go in that direction. So the recent tumor boards that we started was in that direction. It was meant targeted for the younger surgeons, the young consultants, not trainees, to treat their patients in a more multidisciplinary manner. And I think soon we'll be having some webinars on the same aspect. But we need to have more, especially named as mentorship programs. So I was referring to management programs. So that's where, our people can take on.
Also, the rotation part which was going on for the fellows. So most of the fellows, they were telling that 1 month, 2 month rotation, which was there initially before COVID for surgical gastro resident also. That was a good opportunity for them to have role models, work under
But I must
different
share
departments.
that it was not IASG initiative. That rotation was not really a IASG initiative. It was more of understanding between various academic departments as to their strengths in various areas of the same field and the resident sharing between those institutions. So yes, we can actually, that's a very good idea. We can have that as IASG initiative, the resident sharing part. Yes, I agree.
Because it won't require much funds and it's just about the coordination.
Can we discuss all these things during our lunch and proceed for the next speaker? I'm really sorry, we are short of time.
Thank
We
you,
are
sir.
already half an hour late, more than half an hour late.
I would request Dr. Vibha Verma to please hand over the certificates to our chairpersons. Dr. Mahesh Shetty. Dr. Shraddha Ramchandani. Dr. Sonam Mathur. I would like to invite the chairpersons for the next session, Dr. Shruti Reddy, Dr. Tarini Putta, and Dr. Daljit Kaur on stage. And our next speaker is Dr. Shafali Goyal.
Although we might not role in diagnostics, treatment planning, and disease management, they are not given their dues. They often lead multidisciplinary boards, especially in oncology, and as principal investigators in pharmaceutical trials, but they are still not given their dues. They also helps us in implementing various quality improvements, especially in NABH accreditations and laboratory accreditations, but still we don't look up to them. If we see the global data in pathology in 2018, out of approximately 47,000 pathologists, 60% were females. This is not so in surgery. So there was no horizontal segregation. Horizontal segregation is less representation of women in subspecialty. So at least paraclinical branches don't suffer from that. But still there was vertical segregation. Vertical segregation is less representation of female in leadership positions. So in this study, the male exceeded in higher ranking jobs, whereas females outnumber males in lower ranking jobs. So this data from India, which I was talking about, it was in 2017. Again, a small sample size as compared to the outgoing students, but it shows why the paraclinical branches were less opted for. And 4% were all females. None of them was male. So there are various area where women can have leadership role in paraclinical specialties, especially in clinical laboratory management, in quality improvement, in enforcing the quality improvement, especially in developing the antimicrobial data for the hospital, for enforcing the antimicrobial policies, antibiotic policies, and also in the area of research and development. The challenges faced by paraclinical branches, irrespective of gender, is because of their limited visibility, recognition, because in broader healthcare, we generally put decision making in hand of clinicians. Paraclinicians don't have that patient touch, so they often feel left behind. And obviously, especially in private setup, we always judge a leader by number of patients or the finance he brings to the institute, which is not a just system or just criteria for a leader. there are special challenges which is faced by women. This is irrespective of clinical and paraclinical branches. This is based on a prevalent bias that is faced, which is gender bias and stereotypes. So Piyush sir said that why don't we get applications? So it is because of the stereotypes. Because female have less, what do we say, less self-confidence because of the stereotypes they have been facing. They have been made to have that inherent bias that I cannot do it. That will I be able to do it? Will I be able to manage child with my job? Should I apply for this role because I have a child at home? Maybe I will not be able to give that much time to my child. So they generally back out before applying for that job. And that leads to underrepresentation at leadership roles. Otherwise, 60% of the females making pathologist community have only 18% at the topmost position. There are challenges which are faced not only at social level, but also at the organization level, which are often not in our hand. It is at the organization level, which is prevalent among all the private sectors, less in government sectors. So institutional work culture is often, it is patient, policy and service driven. It is based on economy, on finances. So channel of communications are only unidirectional. It is often not bidirectional. So the to accommodate decisions, to accommodate the suggestions is not often there. There is often a centralized power system, especially in private setup, where there is a select committee which will take all the decisions for you. So where there is no scope for a development of a leader in a mid-rung level. Obviously, with age, with you become wise, you have shown your skills, your capabilities, but leadership is not made by age. It comes with time, but it starts early. So there is no scope for development of leadership in centralized power system. Also, there is lack of dedicated funding, which like leadership requires training, skill development, soft skill development, and unfortunately, institutes don't invest much into it. Here, the role of professional organization comes in, like HPB, IASG, which can help the mid-rung level or the trainees to have those skill sets or sponsor them to develop their skills. There are potential barriers to women leadership. It is capability, capacity, and credibility. So we have this self-selecting process. Like women will think that, oh, maybe I'm not capable of it. That's why they don't apply. So that's a self-selection. They always underestimate their own capabilities. They always judge themselves by the eyes of others because they have been judged. And this becomes inherent. This becomes inherent irrespective of the gender. So there was one study which I have not quoted, but in 2011, there was an RCT in US where there were applications for a job by male and female name. And it was seen that male were more likely to be hired and they had a more salary, starting salary. And that was irrespective whether the employer was female or male. So if a female employer also gave preference to a male employee. So that's an inherent bias that comes with time. Also, women have this perception of credibility. So in leadership role, we are always in a likability and competence double bind. This bind, like if we become likable, probably we will not be respected because we attribute different qualities to a leader and different qualities to a woman. So leaders are considered to be decision-making, assertive, and super confident. Whereas women, they are more seen as, not in doctor level, I'm just telling you in general, female are seen as more empathetic, collaborative, and more nurturing. So that they don't mix. So often we have this bind where we want us to be liked, but we are not respected. But if we are more assertive, we are labeled as arrogant or hard to work with. So to promote women in leadership role, Sikora sir will always will have a talk after that. But that's just my 2 cents. It can be done at individual level, organization level, and professional organization level, mostly colleges or professional organizations like IHPB or ISG. So you have to recognize the unconscious gender bias. It is not about male or female mentee. It's about the perception that we have, that female have less technical skills, or probably at the entry level, whether she will be able to work or not. Like some of us, or probably many of us, when we go for an interview, we give our CV. So I have faced it. So people see that what my skill sets are, what I have done, and probably before that or after that they will see whether I'm married or not, whether I'm recently married, whether I will be, whether I have children, how many children I have, and probably they take that also into the consideration. That is an inherent bias that creeps in without our conscious knowledge. Also, individuals can have peer support that Vibha ma'am also talked, and a lot of people talk. We should have a peer support. This group is a peer support. It helps us in coming out. We normalize the bias and we inherit it. But this peer group has made each one of us research, do a survey, and to talk about it and to know what people are facing. So peer group is very important. At organization level, obviously it is not always possible because sometimes it is not in our hand. But sometimes a little change, like in flexibility and family-friendly working hours, not in surgery, maybe in other branches, if possible in surgery as well, is also a welcome step. They should have they should create part-time leadership jobs. The leadership doesn't start with a full-time leadership responsibilities. Each one in the department should be given a assignment or a leadership, work, irrespective of gender. But they should be promoted at the mid-rung level. They should not be promoted at a old age or a high level when your hair grows gray, then only you should be given leadership the work. That should not happen. It should happen right from the start. A small step, a small work, or to assess the leadership skills of your protege. So, as ma'am said, Vibha ma'am, invest in sponsorship. Mentorship is important. Mentorship is using your knowledge and improving and passing it on to your mentee. But sponsorship is using your power to advocate for the job, for the particular skill set that your protege is having. It's not wrong. If your protege is having a skill set and you think that you can use your power to advocate them for a job or a position in the organization, one should do it. That's the only way which has shown in data to make an effect. Mentorship will not do it alone. It is desirable, mentorship is desirable in early stages of the career, but sponsorship will definitely bring in more women leaders. Mind the pay gap. Sir, when you make that project about women in surgery, please put in a question about the pay gap, experience and pay gap, the salary that they are receiving. You will get an idea, a fair idea. We cannot deny it. Government, definitely because of the protocols, it has been standardized, but private, there is a lot of pay gap. Even for the similar hours, more hours, pay gaps is substantial. It is approximately 20 to 30%. And a more suggestion, if while IHPBA, because now the talks are more debate type, so we can have a debate on this between a male or female surgeon, if possible, but probably that will help in bringing out this topic in fore. Because we don't talk about salaries. That's one thing we have been taught. Don't talk about money. Don't look at money. Don't look at finances. But then the finances should be equal. They should be at par. Then we will not talk about it. Otherwise, we will. Beware of the threat of stereotypes. So stereotypes, as I have told you, women have less skills, women are more emotional, women cry a lot. Yes, we are emotional. As ma'am got emotional, it is a good quality. Why do we see it as a negative quality? Women doctors spend more time with patients. As I was having talk with Dr. Ragini, she was saying that her juniors tell her, why do you spend so much time with your patients? Because that helps in developing a relationship. And that's why the patient keeps satisfied and they have a faster recovery. Embrace many phases of leadership. Leadership is not only about autocracy, it's about democracy. It's not about only assertiveness, high self-confidence, decision-making. It's about collaboration, nurturing, and having different views, and then taking a decision. So you have to incorporate all facets of leadership. Don't judge someone on the masculinity of leadership. It should be a yin yang. It should have both masculine and feminine kind of quality. So strategies that, of course, sir will talk about in future slides, but this is for the trainee purpose. We all have been through it. This is just for the trainee. I thought that the trainees will be here. Otherwise, we all know that. So my departing message is what we have been through. Identity. Build a professional identity. Anchor in individual strengths. Identify your strengths early on or build on that. Support. As I have said, peer group. Build a support of personal and professional societies. Also strategize. Design your personal strategies to manage your family demands. You cannot be good at everything at a particular time. So this cartoon became famous. It had been there for a long time, but it became famous when Mr. Anand Mahindra tweeted it. So this says it all. It's not everyone who is at the starting line is not equal. Some have more difficulties, some have more hurdles. We have to overcome them. Maybe we'll run faster, so then we will. So thank you.
So just quick, that particular tweet by Anand Mahindra. So one of the comments was that, in track and field, the starting points for a 400-meter race are different.
So it's just a cartoon.
Because the circumference has to be the same for each and every competitor. Exactly. You saw that the starting point for the outermost candidate was much longer than the innermost candidate.
So, but the hurdles are there.
100 meter doesn't start on a curve. Yeah. I thought it was starting on a curve.
So let's take it in a straight path and a 100-meter race.
I was trying to actually point out that when a gender in track and field, even after that circumference is accounted for, there's still apparently some scientific study in athletics which tells you that the innermost lane has advantage than the outermost lane. So they always compete for the innermost lane. And the ladies.
So that's a psychological advantage, actually. When you see that some person is standing right in front of you and you are behind, so probably that causes some psychological advantage. Otherwise, the distance is same. The data doesn't prove it. The data doesn't prove it.
I think on a lighter note, these washing machines and cleaning utensils should be removed actually. Nobody is washing machines actually. Everybody's got a washing machine now. You're just dumping it into the thing.
There was one more very different picture where it was not just washing machine.
There were some hurdles. There were some,
somebody pulling
the ditches and everything and crocodiles. I saw that picture also, but I found this one.
So actually the talk was very good, Shefali. I think I know we made some changes in the end. I want that the one very important point you said, and I think all of us can actually relate to this. Women, what happens is when we are very assertive, it always happened with me. I used to be very assertive and tell things the way it is. And people say, she's so arrogant,
exactly.
She's like this. Then in your mind starts
you hold yourself back actually.
Then you start becoming you have to be friendly, you treat everybody nicely. Then your coordinators, everybody.
But they will not respect you.
No, yeah. At that point, when I happen to see this very often. At that point, they come and says taking you for granted.
Exactly.
So then that point you have to again put your foot down and say little bit of tone change and little this thing. Then they'll immediately change. It's
like dwindling between. We are in a dilemma. Yes. So that changes our external persona also. And that causes emotional burnout. Maybe that's one of the cause for emotional burnout.
I always take it as for good.
Thank you, Shefali. I think we'll take the want of time. I think we'll have to.
I'd like to invite our next speaker, Dr. Nitin Jagtap.
Good afternoon, all. So good afternoon all. I will be talking about the financial education. If you are earning your own money, you should know how to invest it also. And that's the basic crux of today's talk. So what I'm aiming today is what are the avenues for passive investment, how we can create wealth, and how to learn finance. What we are not discussing is tips, crypto, trading and charts. I have no conflict of interest if I use any specific company name or something that's only for the discussion purpose or education purpose. And be the swan, take whatever good for you, discard whatever you don't like. How many of you meaning of this words, these two words, Valar Margoris? Unfortunately, everyone will die, male and female. And that brings us to the question of life insurance. Life insurance is nothing but a misnomer. It's actually a death insurance. So that insurance is required so that your dependents won't, whoever dependent on you won't suffer in their life if you depart early. So what type of insurance you required? There are multiple types of insurance. Out of them, the term insurance and accident and disability insurance along with health insurance and whatever near and dear to you should be insured. That can be divided into life insurance and general insurance. Insurance in simple 5 statements is you require term insurance. Sum assured should be at least 20 times of your annual expenses plus loan if you have. It should be paid up to 70 years and the payment should be annually till the end of that 70 years period. And these are the standard companies which are offering the pure term insurance. Never buy a insurance cum investment plan which comes with the names such as Jeevan Anand, Jeevan Labh, anything Labh, Satya, anything. That brings Labh and Anand in your insurance agent's life, not in your life. And never opt for this maturity benefit type of term insurance that increases your unnecessary premiums. Coming to taxation, there are 2 types of taxation, direct taxations and indirect taxation. Indirect taxation is common for everyone, such as GST. Income tax, capital gain tax depends on how much you earn. And our primary aim should be to increase our post-tax income rather than avoiding tax by generating cash. If you are generating cash, you won't be able to convert that into asset. And there are various, government has come with 2 tax regime. The crux of all these exemptions and everything comes when your income is less than 15 lakhs, you can claim exemptions and reduce your tax burden. And if your income, annual income is more than 15 lakhs, then it's better to opt for new tax regime rather than doing unnecessary calculations and showing false exemptions, etc. The best approach would be work harder to ensure that your income goes more than 15 lakhs. Previously, slaves used to have chains, but nowadays, current generation slaves have loans and EMIs. So they are in a debt. We can't define which is good loan or bad loan, such as what is good terrorism and bad terrorism, but the loan which can increase your assets, such as home loan, hospital loan, education loan. Hospital means in the business loan. And bad loans which are done on credit card, consumer goods. We have technicians, support staff who are using iPhones with EMIs. That creates unnecessary burden on your pockets. And whatever personal consumption loans are bad. So if you want to define loan in a simple terms, no loan is the best. If it is not possible, then it should be smallest amount, shortest duration, lowest interest and lowest charges. Credit card, there are few benefits, but always remember to pay all your credit card bills immediately. Do not pay that minimum requirement, because whatever credit cards rules are such that they will be beneficial for that credit card companies. So what is financial freedom? Financial freedom is where your passive income is more than your expenses without any debt or loan. So where you can create this passive income. So there are four types of investment portfolios where you can build assets, which is financial, which include equity and debt, physical, which is gold and real estate, and you can earn income from either capital gain, rent, interest, or dividend. There are multiple myths in and around money. Money is not important, but money is important for everything that is important and near and dear to you, such as your health, education, travel, luxury, etc. Money is the root cause of evil. It's absolutely false. Money doesn't buy happiness, but from whatever you can gain happiness is required money. Finance is difficult. It's not my cup of tea. It's also very foolish statement, because it's very simple. It's 7 standard subjects. It's just that we learn gastroenterology or surgical gastroenterology, medical gastroenterology. We didn't learn finance. That's the basic problem. I am busy. I don't have time. Now technology at such a level, you don't have to lose your patient's care, hospital time, child care time to do investment and create assets. So what is money? Previously, we used to have this barter system, then the paper money comes, but nowadays you just get the message. And money is just like a sheer imagination, such as religion. So where is the passive income and active income come from? Active income is where you actually working hard to generate money, which can be your salary or your professional consultancy fee. Passive income from investing, capital gain, rent, interest, and dividends. Another important part of money and its uses. So there are 2 types of money spending, where the product which required you for your needs and product which required you for your prestige and luxury. That we defined as a product of needs and product of prestige. So we can define your product of prestige by very simple test. Whatever you put on a WhatsApp, Facebook, and in show in a party is a product of prestige and not a product of need. You require a vehicle. You require a phone to have a communication with each other, to be in a touch with each other. You require only iPhone, that can be a luxury, but you require a phone, that can be need. So these are 2 different types of assets where you can invest. One is gold and equity. Both have some fluctuation, but over a long term, it will be always giving a positive returns. And debt, which is don't having any fluctuation, but the rate of return is lesser as compared to gold and equity. Coming to gold, there are 2 types of gold spending. One is a jewelry. So jewelry we considered as a necessity expense. It's not investment. If you are considering gold as an investment, then you have this best is sovereign gold bond, which don't require GST, no making charges, no tax. If you keep this for 8 years, additional RBI gives 2.5% of return interest every yearly, and the returns are exponential as compared to when you consider as jewelry or gold coins. Debt products, you all know, provident funds, fixed deposits, government securities, liquid funds, etc. So debt product is where the time is fixed and the amount which you will get at that end of that time is fixed. That means your return is fixed. However, the equity products or mutual funds where the returns are not fixed and the time is also not fixed. So coming to the equity investment, we have these 3 types of portfolio we can develop. One is exchange traded fund. These are very simple passive products which comes from this Nifty Bs or Junior Bs. Nifty Bs is nothing but a collection of first 50 stocks of Nifty 50 and Junior Bs 51 to 100. Stocks, we have these 2 criteria. I'll just explain briefly, or I can demonstrate online also. And the direct mutual funds, which can be of various category. So how to define good stocks for investment? So these are 2 criteria. It is MPTDS criteria, which stands for market capitalization more than 10,000. And these all 4 charts, price, tax, dividend, and sales done by that company should be in the increasing trend. Suppose the price of that company from 2010 to 2020 2020 or 24 should be increasing. Tax paid by company to the government should be also increasing. Dividend paid to its shareholders should be also increasing, and sales done by this company should be also increasing. MD sports requires little bit computation and calculation. I won't be going into detail, but MPTDS will give you a good large cap companies, and MD sports will give you growing companies. Mutual funds, these are packed and branded products which can be of combination or sole alone equity, debt and gold. Mutual fund is not just an equity, but it can be anything. And SIP is not a mutual fund. SIP is just a method of investment. It can be done in the stocks also. Mutual fund is sahi hai is not actually safe hai. Mutual fund can be a good investment starting point, but it's not absolutely safe also. There are two types of mutual fund. One is direct and regular. So I have collected few just for example, such as consider this second SBI hybrid equity fund. The returns from the direct plan is 15.16%, and comparison to it's almost 1 point lesser. If you invest 10,000 per month for 20 years in either of this, the difference comes around 18.79 lakhs. So that is a huge amount of money you are unnecessarily paying in terms of expense to your agent. And however, picking up this type of mutual fund is very easy and simple. So this is the criteria to select good mutual fund. You require a category which can be a flexi cap, large cap, mid cap. Age of that mutual fund should be more than 5 years. Never opt for a newly launched mutual fund, which is called new fund offers. These are bullshit. We don't require that. We require a person who has a well experience in a particular subject or a particular fund. Asset managed by that particular mutual fund should be more than 50 crores. Returns at 5 years, 3 years, and if available more than 10 years should be at the highest in that particular category. So if you are selecting for small cap, it should be at the first top 5 for at 10 years, at 5 years, 3 years and 1 year. Expense ratio should be minimum. Sortino and alpha ratio should be maximum. So these last two are like tiebreaker. Depending on this, you can choose 2 mutual fund from each category. So you'll require around 10 to 12 mutual funds, not more than that. Never choose for sectoral such as IT, pharma, healthcare, or now AI related something. Don't go with a fancy name. They don't offer you any good protection. No, always say no for new fund offer and review once in a year with this criteria. And always opt for a direct and growth funds. So these are take home message. Be self-reliant about your own finance. If you are earning your own money, you should invest on your own. Start learning, take actions, open demat account, choose direct plans, surrender all your ignorance policies, plan your taxation good, and always have a loan-free life. So what I'll do, I'll just go through this website and show you how to see for a good MPTDS stock. We have 5 minutes, sir. Just show you. So this is website called screener.in. So rather than using this Reliance, you can name any company. Motors. So what is our first criteria is market cap. Can you see this? Market cap is first. It should be more than 10,000 crore. It's more than 4 lakhs crore. So it satisfies our first criteria. Yum. Then it comes as P for a price of the share. So this chart is showing price. So Tata Motors price there is some fluctuation, but overall you can see from starting to current price, it's going up. And this dip can be due to during the COVID dip because there is no sale. Then we have 3 most important criteria, which is T for tax, D for dividend, and and sales. So the tax paid by company should be in a increasing. So you can see there is a direct taxes here. So this is overall, if you plot this graph, it will show the increasing trend. There are some dips in between because Nirmala Sitharaman one day woke up and reduced corporate tax from 30% to 22%. Another part is dividend. So dividend paid by the company should be in the increasing trend. And the last part is sales done by company should be also in the increasing trend. Dividend paid is here. There are some dip in between because Tata Motors has acquired JLR and they had lots of depreciation and many other things. But overall, Tata Motors is not doing good in terms of dividend. And the sales done by company, you can see here. So sales from 2013 to 24, it's showing an increasing trend. Apart from dividend, the Tata Motors, I think, is fulfilling this criteria. For mutual fund segregation, we have this value research online. You can just go in this fund selector, select the category. Suppose here now Flexi Cap has selected, and you can search from here. So expense ratio comes here. It should be minimum. So can do up and down and see the maximum is 2. Never choose this type of mutual funds. So who is having expense ratio 2.5, that means it will erode 20% of your profit. Any questions? We are happy.
Thank you, Nitin. That is a very beautiful, crisp this thing actually, for some very beautiful tips that you have given us actually. Some of us actually may not be looking onto these charts also. But actually, instead of checking Instagram, I think you should be checking these things actually. I think you'll make more money checking this rather than Instagram. Actually. Instagram, you lose money. Actually. You try to compare yourself with somebody else and lose the money.
How many people in this audience know about WealthCon? So it's just, you're probably 30% or less. Would you like to talk about your group? WealthCon was founded by Dr. Ram, who is a medical himself.
This is a group of we have reached more than 50,000 post-MBBS doctors. This group founded by Dr. Ramnath Gute. He is consultant radiologist from Mumbai, and he is doing just phenomenal work. Not only in the finance, he takes classes about health. I lost 10 kg of weight after following him. Also, he teaches other aspects of life such as meditation. He used to take classes about Bhagavad Gita and many other things. So
this is what I was talking about. This group never
invited.
went onto a stage. They started this with very few numbers online, and now it has grown to more than 50,000 people, active members. This is one very group. I mean, I think you should all follow this actually.
Have many WhatsApp groups, and they have classes as well, and classes for different grades of people, beginners and for the, I think, platinum and all of these things. I think, women are very bad at handling finances. We should.
Who said that actually?
I mean, doing this kind of things. Doing this kind
trading.
of things, doing equity or mutual funds or trading or any of that.
So everyone need not to do trading. Trading sometimes it's like you earn from someone losses. But if you invest for long term, so long term we define as 7 years. So where if you invest for long term in particular Nifty or something, then it creates a wealth not only for yourself but for nation also. And those who are not having, this might be provocative, but those who are not having demat are the burden on the country.
I think that's a very good statement he made actually. I think everybody should have a demat account actually. The other thing is actually we can start the next session now. I think it's a very good statement actually. Actually, the next generation are not investing too much in jewelry. If you see, the older people are the ones who are investing in jewelry, but not the newer generation never talks about jewelry. That's a very good thing that has changed the entire concept actually. Thank you, Nitin. Thank you so much once again.
I'd like to request our chairpersons to hand over the certificates to the speakers. Shruti ma'am, if you can hand it over to Dr. Nitin Jagtap. And Tarini ma'am and Daljit ma'am, if you can hand it over to Dr. Shefali Goyal. I'd like to request Dr. Nitin Jagtap to please hand over the certificates to our chairpersons, Dr. Shruti Reddy. Dr. Tarini Putta. And Dr. Daljit Kaur.
Now we move on to the next session. I would like to. Yes, ma'am. Sure.
Okay, now it's like the marks time, report card time. No, I'm just kidding. So it's very interesting that apart from the 4 groups, we had a control group of physicians who are with us. So they've also answered the same questions. And it's quite nice to have an outside, sort of an outside perspective of the whole thing. So leadership position, expectation from co-leaders. Bring more collaboration in leadership in decision making, and not be autocratic and have a democratic style of leadership. Space to grow, respect individuality, give due and allow progression, provide visibility, allow fair ground, equal ground, high moral compass. I mean, irrespective of man or woman, I think this is quite clear as to what everybody's expectations are. So this is interesting. And similarly, so what do staff trainee or staff or early career people expect from their colleagues? Very similar, be it at whatever position. So they've said no discretionary behavior. And again, we said this is all women crew. Even there you feel this is very important. So let's look at it like if there is one man in the group, he would also expect the same thing. So it works either way. So let's say, I think I touched upon this yesterday in the panel discussion. If you're taking a pregnancy break, that they could consider as a discretionary thing. So we have to slightly look at it from the other perspective also to understand how we can change things around. I know sometimes it's more, we feel more biased because we are smaller in numbers compared to their numbers, but we'll have to put it ourselves in their shoe and also see how we can balance this out. Flexibility and support for change in duties, cooperation, solidarity, basically better interpersonal relationship. I think this works throughout careers, right? Starting from your early level to at all levels. Very important, acceptance that women are your equal colleagues and start training early on. This they say at a trainee level itself or early level. So our recommendations probably should kind of get all of this together. Leadership expectation from colleagues. I mean, very interesting here is the last point. Don't take it for granted. So this is what your women leaders expect of women trainees too. So when a man expects the same from us, we should not look at it as a bias or a discrimination. Sorry, I'm talking at the other extreme. I'm just trying to open up our mind so we know what we want for ourselves. And the last is expectation of trainees from the leadership. So even if you're a woman in a leadership position, let's not get biased that if you let a woman colleague do certain things, you might be found as, allowing a quota or something like the discrimination there. So let's keep it professional across genders. And these are all points all of you brought about is very neutral statements, except 1 or 2 here where you should, and something which is very interestingly spelled out in the trainee to leadership, I think, or trainee is networking, more networking. Don't do only the boy culture thing or the man alone thing.
So let's go to what the neutral group said. This is the most interesting part. They say, why do we need a separate women's wing? This is what the physicians feel. Why don't you just look at it as a neutral thing and, have equal opportunities and start at a trainee level to influence this and get objective feedback. So I'm going back to what I put down very much on the same lines. So these 4 slides were inserted now. What I put these down was much earlier, and I'm quite glad that all of us are on the same page. First is acknowledge the sore points that we have. I think from the feedback that we got, we can take out at least 2-3 points for every level, put that down and try to see how we can take it forward at women in surgery societies before getting to very specialized societies, because this starts early on sensitization. I think it's going to go a long way. Perseverance, because it's a very long road ahead. So start early at this general surgical level. We may not reap the benefits of this change because it may take another 10-15 years. That's okay to start somewhere, I think. And multiple small steps are important. These are the proposals. One is sensitization on inclusivity. Start at trainee levels, at societies, at organizations. Make this a mandatory thing. Clear-cut structure for compensation. And here what I refer to is, if somebody wants, the guy could want to take a 3 months off, the girl could want to take a 3 months off. Have a structured way of how you would compensate and repay this. Don't let it loose. Anything let loose will lead to trouble. Have a definite way for that. Organizations should start investing in families. Talk about the person, their spouse, put it male or female. Child care and adult care is going to become very important for all of us. We're going to have aging parents, we need to address that. Socializing and networking to be more broad-based. Create opportunities for flexibility in practice. Think about part-time jobs. We all are always talking about full-time jobs. We need to start thinking how to work on a part-time basis or get into group practice. That's a fantastic way. Some specialties are structurally group practice, liver transplantation, whereas others are individual-based practice. Once you move on to group practice, you get a lot of flexibility. Negotiate, both at work and at home. If your priority is to spend time at work, you should negotiate at home. It can't be different. And professionalism at all levels. I think these are the points I would put forward as leadership requirements for a better workspace culture. I'm happy to put this down as a draft or something, circulate it. All of you can put down points and we can see how we can get it to a bigger society, groups, and address it. Yes, sure.
Thank you, Dr. Gomati. I think we'll proceed to the next section.
Now I would like to call upon Dr. Anusha, Dr. Gayatri K, Dr. Nandita to chair the session. And I would like to call Dr. Shraddha Patkar ma'am.
Speakers, please stick to time. I think we are running really late.
Good afternoon, everybody, and thank you, IASG and IAG, for calling me for this talk. So the mandate is to speak on patient-centric holistic care and to explore the role of women surgeons. Again, this could be a general neutral topic. This is just examining the role of surgeons. I had to do a research on actually what the definition of holistic care means. It is actually looking at the needs of the patient, not just their physical ailments, but also the emotional, social, and spiritual needs which a patient has, and then focusing it on the patient's experiences, what are the patient's values and preferences, to see whether we can deliver better outcomes as women surgeons or just as surgeons as in general. So one of the advantages which have been proposed in literature also that if you can multitask, it is an ideally suited environment to be a holistic therapist. And if a woman is able to multitask at various avenues, that makes her a better placed physician. So I will be examining the vital role of women surgeon in providing compassionate care, whether we have unique communication skills, cultural competence, and dedication to understanding diverse patient needs. Coming to each of these aspects, again, compassion is something which I had to look up. What is the exact definition? Is it same as empathy? Is it sympathy? Is it altruism? It actually literally means to suffer together. If you have that feeling of compassion, it is defined as when you're confronted with a patient who is undergoing suffering, you feel motivated enough to relieve that suffering and do something to change it. These concepts in psychology or sociology are related to empathy and altruism. They are not interchangeable. And there have been some literature which suggests that women surgeons have reported to score a better percentage rating in, with patients in relation to empathy and compassion. Communication skills, again, has various parameters. It has empathetic listening, effective dialogue, and this all helps in shared decision making, where again, female physicians are reported to have better communication skills as compared to their male counterparts. They excel at active listening, validate patient concerns, and then this fosters an open judgment and a free dialogue with the patients. Again, helps us to communicate in a very clear and lucid manner, helps the patient to understand their condition and what is the treatment plan proposed, ultimately empowering patients to take good decision in their best care, and they sort of feel involved in the decision-making process. We come across diverse patient populations, and each of these may have different needs. It helps to have a personal approach, tailor each decision to their cultural, religious, and social needs. This helps again to foster trust and breaks down language barrier. We face this a lot, especially at a tertiary care center. We get a lot of referrals from patients who are outstation, and there are a lot of language and cultural barriers. Enabling a good dialogue between patient helps to provide equitable and inclusive care. And then we should be aware of our own biases while we deal with these patients. Again, literature says female surgeons report a 25% higher rate of cultural competent interaction with patients, and with a essentially reported better patient satisfaction rate. This is something which I found very interesting. Cultural competency development model. It is not just, it's just awareness of your own cultural values and bias, as long as you know what the other person also believes. There is knowledge of other views and the world overviews, which helps us to develop strategies and practices which can be mutually beneficial. There are unique needs of women patients also. There is, for which gender-specific expertise is needed. This helps again in providing specialized care. We want women's health issues to be prioritized. We want actually the government to take some action regarding health policies, which may be beneficial, especially when it comes to screening programs. And sometimes it's a natural thing that women patients feel more comfortable with lady surgeons, leading to better outcomes. I know this is especially, we see it a lot in oncology, where we have breast and gynae patients who specifically ask for lady surgeons, and they are more comfortable talking about their problems with lady surgeon than me. Elderly patient is something which we are seeing a lot in our practice, especially as a surgical oncologist. We've seen that a lot of geriatric population comes to our hospital, and again, addressing their special needs, age-related healthcare issues. They have a lot of comorbidities which needs to be accounted for while we plan their management. And most importantly is the ability to take time to listen and understand, and they tailor the care to their unique physical, cognitive, and social needs. And also, more importantly, to provide caregiver support. They sometimes we see a lot of patients who don't have a very good social support, and that kind of leads to attrition in taking treatment. So giving caregiver support also helps in fostering better care for these patients. There are patients with disabilities. So this is another unique population which we face. We can ensure that the practices are for them are easily available. There is availability of alternative communication methods so that you can engage in a better dialogue and understand their problems better. And this helps to, again, tailor better treatment according to the needs and abilities for each patient. So there has been some evidence of women surgeon in patient-centric care as related to improved outcome, higher satisfaction, and reduced disparity. I know the next talk is on patient outcomes, whether it's better for women surgeon. Just to touch upon, studies have shown that patients treated by women surgeon experience lower mortality rates and fewer complications. There's, in general, a higher satisfaction reported by patients with their care and communication, with a reduced disparity. Now, this merits a lot of questioning whether what kind of surgeries and whether this is actually a bias in reporting. But this is what we have. I'll just touch upon a couple of things before we move on to the next speaker. This is long-term postoperative outcomes in patients undergoing common surgeries, and this was a large patient population with better outcomes reported when operated by female surgeon. This was published in JAMA last year, and it stirred a lot of talk on social media as well. And this difference was shown even 1 year after surgery. The healthcare costs also for patients undergoing common surgical procedures from a large database from Canada showed that there were lower healthcare costs for patients treated by female surgeons as compared to those by men. And they ultimately say the same thing, that you need to have inclusive policies and environment with support of women surgeons to help not only recruit but retain a lot of diverse workforce. This is something which is specific for GI. A study in Karolinska in Stockholm, where patient reported outcomes post-cholecystectomy showed that there were lesser hospital stay, bleeding, and conversion rate when patients were operated by female surgeons. This is a very nice slide, which actually sums up what all of us want to give, especially in an academic institution, that it's a real privilege to care for patients when they are at their most vulnerable. And being in an academic institution allows you to conduct research and develop protocols and make maybe path-changing decision in future. And the advantage to train and mentor the next generation of surgeons and scientists is a great feeling. And we are lucky to have now so many residents who can benefit from the experiences of great mentors who are there here. And this is a great initiative which has been started by IASG, and we hope to build on this. And thanks a lot again for having me here. And I would like to take this opportunity to invite all the residents here to our annual Surgical Oncology Conference, which is basically live demonstration, provided we get permission from the NMC to do that. And we hope to see you in Mumbai soon. Thank you.
Can I ask you a small? So, excellent talk, Shraddha. I really enjoyed it. The compendium of literature was something which you want to look forward to. So, I'll just draw a parallel. So, let's forget gender-specific outcomes. Let's just go on to hospital volume-related outcomes or surgeon volume-related outcomes. Those studies started 50 years back, and they led us to a point where we realized that centralization may be an option, and larger volumes lead to a better outcome, and hence, so actionable points. I'm not entirely sure what is the actionable point here. When you say that female surgeons' outcomes following cholecystectomy are better, I'm not pointing to you, I'm just saying, what is the study trying to say?
Yeah, so exactly. So this study, all of these studies have come out in the last year and have stirred a lot of discussion on social media groups as well. I think we need to take them with a pinch of salt and look at the broader picture and whether they have reported any specific outcomes or whether it is like one study only looked at costs. So, and the reasons why they found these. None of these studies have alluded to why they found this difference. They've only just presented the results as they found it.
I'm just trying to ask, somebody must have started this study, there must have been a research question. The research question could not have been genders produce different results. That could not be the question.
That couldn't be.
But patients don't read journals. Patients don't read journals, no. So it is
Yeah,
for
so
public
that lies the role
consumption.
of social media.
So then it's not science anymore, right?
Rajneesh, it is fashionable and main thing, Me Too movement for every organization to say equity, diversity, inclusion. These three words are the catchwords, and every journal is publishing papers on equity, diversity, inclusion, and everybody is researching. Sorry? So I'm not sure what has caused, what hasn't. I haven't looked at it in a sort of systematic way to say anything on that. Maybe you have, and maybe you're right, but
I think can we go for the next speaker? Yeah, we should stop it here. We'll discuss. I think we'll have like a good lunch and then we'll speak. Please, for the next speaker, I think.
Moving forward, I would like to invite Dr. Sadaf Ali.
Very considerate executives of ISG, the president and the secretary, taking the cause for last couple of years now. And I believe it has been more organized this year. The topic selected by Sumana and the program circulated was expected to be crystal clear, but then it happens that you would have a lot of overlap with all the speakers, where the common cause is we are thinking about the betterment of women delivery in GI surgery. My apologies of not being present yesterday. I have been assigned the topic of patient outcome is better with women surgeons. I get greetings from Sher-e-Kashmir Institute of Medical Sciences, where I head the Department of Surgical Gastroenterology. So I thought of looking at these questions, first thinking about some general characters of women. And these lines by Frank Ocean is very apt. There's some magic in truth, honesty, and openness. And another fact we generally believe about women is, and we agree that women tend to organize cures. So then the basic question comes that if you want to come to an answer or conclusion whether the women are better, then you have to address the question that what is the role of training and skill. There's no dispute that both male and female surgeons undergo rigorous training, education, and then they become proficient in their specialties. Skill level is very important because skill level is directly related to outcome, and it is not influenced by gender as such. So the answer is it doesn't have much role, because skill is influenced by your experience and expertise. If you have come out from a same training center with same teachers, and one who is more passionate about going with the subject, going to the best, and giving more years, more time, 7 out of 24 hours as compared to 3 out of 24 hours, it would definitely reflect on the outcome. Now, coming to why, where can we be different then? It has been touched upon by the previous speaker. I think communication with patient is an important area where women are usually want to excel. Because of their approach and patient communication and empathy in their communication, this could potentially contribute to patient satisfaction, and as well as their patients are likely to adhere the post-operative instructions, which can indirectly affect the outcome positively. Another important factor that can influence and create a difference when you talk about gender is patient preferences. Now, we all have discussed about the numerator and the denominator. Like, of course, we know that there's so much of inequity amongst how many women surgeons are there as compared to male surgeons. All those factors are going to influence the outcome. You might be having 1:10, 1:20, 1:8, but then you don't have differences in the number of patients. We have patients are either men or women, and they equally get sick and they come to doctors. And then an important thing is that, you have some diseases which have more of female preponderance. Some patients, especially, look for better preferences and comfort levels. In fact, most of them. And especially this kind of female subset of patient might feel more comfortable with a female surgeon. And the two develop better communication and trust with each other, which can positively impact their experience, the overall experience of their ailment, as well as can have better recovery. Now, coming to what does research say? Recently, there are some studies which concluded that patient outcome is comparable or even slightly better with female surgeons. This is seen in certain specialties and particular procedures only. So you cannot make a common statement about it. And the findings are not universally consistent, and it's not across all disciplines. This is data about cholecystectomy, which she also gave a running reference to the previous speaker. This is on a large number of patients, 150,000 from the university, which talks so much about bile duct injuries, complications, very good data. And they have observed that patients treated by female surgeons suffered fewer complications, shorter hospital stay. They also observed that female surgeons operate more slowly than their male colleagues, and they also found that they are less likely to convert into an open surgery. So these are just results. Another paper which was quite discussed everywhere and rotated into all possible sort of groups from the JAMA, which even that she tried to touch, which included so many surgeries, almost 25 odd procedures, right from heart to all organs, between 2007 to 2019, nearly 1.2 million patients were evaluated. This is a Toronto-based university study. And they have said that the 90-day adverse events were slightly less in female patients against male, 13.9 against 12.5. The follow-up with female surgeons, it was seen that at 1 year also the adverse events were less, 20 versus 25. 21 versus 25, and the mortality was also less, 2.4 versus 2.1. So as somebody put up the right question, that what was the genesis of this study, and there would be so much of confounding factors into it, because you don't know whether it was taken care of in all aspects, but it looks like they have tried to put up a fair standards study. And what does male think about? Then this was discussed elaborately at various levels in various meetings, as we are also having a few meetings for last few years. And the chief of the project actually gave very interesting remarks that as a male surgeon, I think these data should cause me and my colleagues to pause and consider why this may be. This is another study which I would like to share. It comes from Japan, which is more neutral, and it looked into two areas commonly performed over there: gastrectomy and LAR. They looked into early complications, and their female patients were just 5% or around a little point of percentage difference. 95% were male surgeons, and the 95% of procedures were also done by the male. And it was the one different point was that the women had less number of post-training experience when they tried to look into statistically as compared to the male counterparts. And with adjusted differences, female had similar results in terms of complication. Women had, they also understood that women did less number of laparoscopic surgeries in these areas. And they concluded that we need more women surgeons in future. Because they have equal number of complications. So this is where they give you space and understand that at least they are equal. And then we have talked about a lot of gender bias. I'm not sure if somebody has covered this study or not, but somewhere it also proves a little superiority in terms of confidence in treating patients and women students, where they have paired for appendectomy male and male faculty student, male and female faculty student, female and female, and then female and male. So it was seen that to their procedures and their self-assessment and faculty assessment, both male and female faculty gave more points or marks to the female students, one. And second thing is the female students gave more points to themselves as compared to the male students. This is another study in Annals of Surgery, which looks to include 5 retrospective cohort studies, concluding that a little difference in mortality. Female tend to have less mortality. Again, there would be a lot of bias in selection criteria. It depends on what patients you're taking up, how complicated you're taking it up. And the complications are same. So the previous study by Christopher group, which discussed about cholecystectomy, actually also published in BMJ that the overall healthcare cost by female surgeons were less. So as rightly said by previous speaker and many of you, a lot of news was created. You know, every second journal started writing commentary about these papers, and I tried to search that if we have a lot of literature to support these statements. I could not find much because everything was hovering around these few papers, and to me, there isn't much literature. And some statements, again, discussing these papers, like they sound to be very catchy. Women in surgery, bright, sharp, brave, and temperate. So I would put my personal views over here. A very good positive thinker would say that when you want to do better, don't get ruined by praises. Get saved by criticism. And there is no answer to deliver better, to prove yourself better, except for means of focused hard work. So I would just summarize my talk saying that there are only few large nation-based studies documenting that female surgeons are better. More studies are required to answer this question. This question goes unanswered, or at least my agreements are not there. Undoubtedly, women surgeons work with more empathy, sincerity, and patient-centric approach. There has been more news created after these publications in good faith, I believe, to boost the morale of women surgeons. I am not a proponent of coming to conclusions on survey basis, so I did not generate any surveys with male and female surgeons coming to an answer that who is better, because it's all a game of skill and experience, and there is no end to learning and acquiring skills, which are key factors to outperform others. It is very likely that in near future, women may be more sorted for surgery and might dominate the field. Thank you very much, ladies and gentlemen. Not to overlap with other speech, I would just still take the last point on that diagram, that if you have a women leader in the circle, in the loop, and if you have three in one of your junior, if she has been a woman, is very likely to become a leader in future. So this is an impact of positive leadership when compared to male. There are many more things in that they will do better in most of the areas. So I would be happy to answer any questions or deliberate any discussions on my viewpoint.
I'd like to just summarize. I think Sumana is constantly keeping tabs on the time. Very lovely presentations by both the speakers. I think we cannot obviously generalize these studies and absolutely say women surgeons better than men. But the ultimate aim, I think, of this study was not to change the perception of men and women doctors versus each other, but maybe this goes to change public opinion of the way they look at women surgeons. It's very similar to you feel safer when you're with a male pilot rather than a woman pilot when you're going on that Indigo flight. So similarly, I think patients' perception, because we often do get discriminated by patients and not so much in our day-to-day life by our peers. So when these make news headlines, I think it does change patient and general public perception that even if women are not better than men, they should be at least looked at on par, and their skills should not be judged exclusively based on their gender.
And this holds true for what you said is for every field. Like
Every field,
why
absolutely.
shouldn't be a female pilot be better than a male? Or why
Absolutely.
should you
Sorry to
think twice?
kind of disagree with part of what your statement was. Science should be kept away from
Yeah.
rabble rousing.
I agree with
I'll
you.
give you a small example, which I think Dr. Piyush gave me when I was a resident. And this was a scientific study long time back. It was ultimately proved to be a fraud, but it's a very good example that bone marrow transplant improved outcomes in breast cancer. It's a South African study, correct? And apparently, because it was shown that they improved outcomes, the entire insurance sector in the US was now riddled with complaints about not being offered bone marrow transplant for improving breast cancer outcomes. Ultimately, it was proven to be a fraud. But this is science. If you say at this point in time, JAMA has published that female surgeons are better, you can see what could next happen. And what can be the outcomes, potential outcomes of using science for making a point. So you have to, I think the point.
But most of us who would look into
why.
this science would look with very critical view that what are the differences, and then we know how we then go into a journal club and assess a paper. So that all details are to be seen into it. But as a topic oriented this thing, I have my own disagreements because it's a huge field and it's a dominated field by male. So it's you cannot come up with a statement that they are better, but they are equal. We all discussions about being equal.
These debates will keep going on, I think, even for one more decade. So let's actually get on to the next session. Thank you so much, Dr. Sadaf, and thanks for the great comment, Nandita.
I request Dr. Gayatri K to present certificate to Dr. Sadaf Ali. I request Dr. Sadaf Ali to present certificate to Dr. Anusha. Dr. Nandita.
Excuse me, Sumana ma'am. Ma'am, here. Ma'am, I have one proposition to the group. Just like the Association of Women Surgeons and the Women in Surgery groups in Europe, especially Italia and other countries, Scotland, etc. Why don't we have a web page with a blog and an Instagram page? Like Sir said, we should be active on social media. No, ma'am, separately, and it can be endorsed by the IASG. It doesn't need to be under IASG, but we can have a link on the main page of the IASG linking to this website. And instead of having an Excel sheet to show who is good at what, we can have a feature like the AWS, they have a Friday feature where they give, one consultant and Sunday for one student.
We'll call on to
Sunday
the next
spotlight.
chairpersons, please. We'll
I'd
continue
like-
the discussion. This is separate from that. You please continue the discussion.
I'd like to invite the chairpersons for the next session on emerging trends and future directions, Dr. Piyush Sani, Dr. Shreyas Modak, and Dr. Sadaf Ali onto the stage. And our next speaker is Dr. Sadik Sikora.
Thank you very much. We are at the end of last two talks of this wonderful meeting. And actually, I feel really an immense sense of joy, fulfillment, and satisfaction because I think we are part of a movement, which is a movement of change. And it's always exciting to be part of that. The second thing is I'm not going to speak anything new because I think over the last 24 hours, we've been repeatedly talking about this. So I'm just going to kind of collate these things. You've all spoken about it, especially in the leadership, policies, and finance things have been covered. Nevertheless, just consider this as a collation, a summary, and some suggestions. So we know there were trailblazers ahead of us, much ahead of us, so it's not something new. But I think we have fallen down at or sort of stagnated at some stage, and we need to reach that pinnacle all over again. This slide we have seen that women in surgery and in leadership role in Asia is abysmally low, and the usual suspects are harassment, unequal opportunities, work-life balance concerns, which we have debated and discussed all along. These papers have created a lot of talk. That's the team with us about 4 years back. And it's all women team with the odd man out. Unfortunately, that's me. We're talking about the traits, and these traits, I think the double X traits, I deliberately put it like that because subsequently we'll talk the paradox. And these are actually wonderful traits. I don't know why people want to shy away from those. Compassion, empathy, humility, kindness, collaboration. Because we are talking, when we are discussing this topic more often and in published literature, we talk about double X paradox, wherein the leadership roles, as Shefali I think mentioned, that you are expected to be aggressive, show strength, take tough decisions, and then come of age and be a leader. But I think the other traits or the feminine traits, let me put it like that, not that it should only with women, men should adopt that also. And especially in the healthcare sector, where we are looking at the kind of patient population who's distressed, is vulnerable, these traits are very helpful. So why not have that and change the definition of leadership, how it should be? Why the stereotypical, efficient traits which are associated with male? And I think Vibha mentioned that they have to adopt those traits to be able to be seen as a leader. I think you need to redefine that and go on with the traits which are valuable. And I admire Jacinda Ardern, the New Zealand Prime Minister, and she said that one of the criticisms I have faced over the years is that I'm not aggressive enough or assertive enough, or maybe somehow because I'm empathetic, it means I'm weak. I totally rebel against that. I refuse to believe that you cannot be both compassionate and strong. I think that this resonates in all of you that I see around here. Now, again, when you talk of leadership, I mean, if it's a bottle, we know that there is a bottleneck at the top, and everyone is trying to push that. And we've understand these concepts of glass ceiling and the broken first rung. I think it's a combination of all. I don't think it's one. We have strengthened the bottom rung. People we can see now coming up to do surgery and surgical specialties. So it's no longer a broken first rung. Of course, there is a ceiling somewhere. So it may be a combination of all of these which challenge the attaining the leadership positions. And in response to that, this New Yorker cover page showed these, I think it's plastic surgeons, they were talking about OT light, and it's started a viral trend with everyone putting the pictures there. But it told us that there is attention paid to this, that this needs to be recognized, that women and surgery are not something which not made for each other. So we've been talking about this gender equal representation as a moral imperative. It is, but it has to move beyond symbolism. For us to A, make a dent, and B, it inherently will make the decisions more smarter, ethical, and effective. And I believe in that because I've seen that when people are in that position, I mean, the women, they make much smarter decisions. So where we are now, so let me quote this. If it's a problem Urdu to some people, we can help. कोशिश भी कर, उम्मीद भी रख, रास्ता भी चुन. So all three are there. You all have done that. फिर इसके बाद थोड़ा मुकद्दर तलाश कर. And then look for some support with destiny and many other things. So Nida Fazli said this. So my or our 7-point mantra could be one, and we have all talked about this. So acquire skills. I think that's the, and maybe it's gender neutral, but everyone needs to acquire skills. And I think many of you spoke about this in a specialty that you have chosen, or make a niche area for yourself to be recognized and be a leader in that. If you want to be a leader, anyone, you need to also broaden your perspective in terms of understanding research methodology, design, so that you can guide people, be a leader that who you are. We all talked about, we are not all, we may be born leaders, but we may not be able to manage the things which come with leadership. And for that, we need some workshops, some training. I can imagine what would be, she's not here, Anu, who's become the head of surgical gastroenterology, and the difficulty she would probably face with the office staff, the way they would look at her decisions and or dilly-dally in implementing what she says. So not only getting there, but to do things, you need to have man management skills, and man managing bad men skills also, and colleagues also. So you need to develop that skill. Of course, the other skills, I think that also one of you mentioned about communication, problem solving, and emotional intelligence. So in short, you need to equip yourself to be able to get to the leadership position. Networking or not, so this was at lunch. So we all gravitated to one table, everyone else to another table. And this is the dinner. Look at the faces. GV is saying, I have to again sit with Sadiq, talk the same thing. Look at these faces, joy, fun. GV, we could have been together. So networking, everyone said that is important. So you need to, it comes in various forms, but present your work, discuss, interact in conferences so that visibility and people recognize you interact. I want to emphasize that you should use all opportunities that we all have to showcase your skill, talent, and prowess. So you need to grab those opportunities. And as GV said very emphatically, that you need to use the social media to your benefit in appropriate ethical manner. But it provides you a platform without looking for any support to do or showcase what you can do. Again, Vibha talked about this mentor and mentorship. I think it is a very important step, component. Everyone needs it. But how I look at it is find a mentor who's closely aware of your work, skills, and expertise. And most importantly, who believes in you. Because unless that kind of equation is there, the benefit which we saw of mentors and mentees, how they would benefit, may be a little at a lower level. The mentor, whoever it is, has to be your advocate and should be able to recommend and also guide you towards the opportunities and positions which may be available and are known to them. I think Vibha showed this, that gender is unimportant as far as mentorship is concerned, and I totally agree with her. There may be role models, but mentors could be from many genders, and all men mentors are not bad for women, and vice versa, all women mentors are not necessarily good. So I think each one has to choose a mentor based on their association, what they want, and how they want their career to progress. The fourth thing is demonstrate leadership. I mean, it's not that when I reach a leadership position, then only I should act or behave as a leader. You need to constantly in your everyday life show that you are leader. And there you will be seen, observed, acknowledged. And again, this is for everyone. So you need to volunteer to spearhead initiatives and various other things in your organization, in associations, in any which way, which will show that you are able to lead a program. Again, same thing, research projects, thesis guides, and training young surgeons. I think in that also is a form of leadership which you can. And as I've been saying, that you need to be part of something which makes an impact and shows or improves your visibility. And not only that, in that position, also deliver. Because at the end of the day, the value of anything that you do is measured by the deliverables, what you deliver at the end of it. The fifth one is have a proactive stance. I mean, we all say, I don't get this opportunity. I could say for this reason I didn't get. But if we are in a minority or being discriminated against, it is a rule that you will have to work hard or harder to prove your mettle. And we should all be prepared for that. If I have to do this, I will do this. I will take this challenge. I will take every opportunity that is there. And as we discuss, in this long road, I think Gomti said this, that you need to have grit and perseverance. It's not that it's going to come about the next day or next week or next month. But if you have chosen that, then you need to go ahead and do it. I'm a strong believer of women advocacy. I think there may be differences of opinion. I see differences here, but I think it provides a platform which is visible. It is an acknowledgement of this group, and it can advocate more vociferously and with more, I should say, strongly the issues which are important for this group. And generally, as we discussed yesterday, organized group, larger numbers have ability to have more impact. And therefore, we should strive for this, is my recommendation. And finally, it takes two to tango, and men or other organizations have to do something, as Shefali showed those three columns. So we need to break the stereotypes that these kind of leaders are what we want. This is not the only one. We have to validate women leaders, encourage, give opportunities rather than provide roadblocks. And more importantly, I think we need to sort of, if you are in a position, to let talent come up rather than suppress it. And we see a lot of talent in a lot of places, and you need to support that and have a proactive role. Not that if somebody asks you, you do that, and you may be proactive in recommending something who's a good talent. And even if there is merit, at times it needs that support, that boost, that backing of a credible source. And if you have a credible mentor, that would make it much more easier or valuable and have the impact. So at the end, I think it's the story of this. मैं अकेला ही चला था जानिब मंजिल मगर लोग साथ आते गए और कारवां बनता गया. So I think we need to get together and widen this group and have more numbers. Thank you very much.
I'd like to open the talk for any discussions. So moving on, our next speaker is Dr. G.V. Rao.
That was a great talk, Sadiq, actually. I think, again, as Dr. Reddy was saying, actually difficult to follow you again. And again, a difficult topic to. If this, the same pictures what Sadiq has put up, if I put it up to the artificial intelligence, it will say that men are more stressed, women are more casual. You understand what I'm saying? Sadiq is saying women, you can say, you understand, if you just put it up to the artificial intelligence, the way it perceives is totally different. So this is a disclaimer. Actually, some of it is evidence-based. Please, no personal comments against anybody, please. Now, this gender gap seems to continue over civilizations. The percentage of gender gap is different in different parts of the world, as shown in this graph, but it persists to variable degrees over the centuries until today. Now, this is the last year data. 2 movies got released, Barbie and Oppenheimer. Surprisingly, Barbie earned more than this. But when it came to Academy Awards, when people started voting, Barbie lost out. It is basically, if you see the statistics, it is not because just men voted against this, but a sizable number of women also voted for the other movie. So you cannot say that the gender gap is just at one level. You understand there is different perceptions of this, and one perception cannot be equated to everything. There are gender gaps actually at various levels. Actually, we've been discussing the last 2 days. Actually, pay, the post, you ask parity, perception, prospects, progress, projection. All these are the areas that women keep talking about where there is some amount of gender gap. And we just have to see whether artificial intelligence can be of any help in bridging this gender gap between the men and women. Now, this is becoming increasingly the mainstream across all sectors of life, whether you like it or not, and it seems to benefit the society. And the potential can only be realized if the technology represents the diversity of the population that it addresses. It cannot be one population who is developing the system. Is AI gender biased? Yes. As in today, evidence says AI is gender biased, basically because it is developed by predominantly men, and the image recognition, what it does, is predominantly developed by men. Beautiful movie called Coded Bias, which shows that when you're screening these people, looks like majority of the people who are taken into this study are men and not women. And it's study from US, which again shows that some of the black
I
women
started
were
looking at the data sets themselves,
excluded
and what
from
I
this study.
discovered is many of these
Phenomenal
data sets
study, which movie,
contain
which shows why this coded bias, why this is
individuals. So
AI
the
is
systems weren't
biased
as
as in
familiar
today
with faces
towards women. Now, does AI also have a male and a female AI? That's a question. Okay, you're developing a thing, I call it male AI, compared to a female person who's developing a AI, which could be called a female AI. But as in today, it's a machine. It's not a human being. So we feel that there is no gender bias as far as AI is concerned. But it is the person who is developing, who is putting in the data, who is important in this. Now, AI can understand women as a gender more as an individual. Human emotions are complex and evolved over centuries, and it's hard to decode subtext beneath our emotions. As in today, we can only get to certain level of understanding, and we need biological algorithms as compared to non-biological algorithms, which should be incorporated into this to make sure that there is no gender bias. And also, AI cannot understand the cultural differences, because smile might denote one in one part of the world, it can denote something else in another part of the world. And AI just learns from the data. What you feed is what you get from the AI. And the data as in today is definitely gender biased as in today. Now, data is destiny, actually, unless and until, even in our systems, actually, if you're doing any research, whatever you feed, whatever you want, what you want to get. But you cannot go retrospectively and say that you want to get this result and that's how you want to feed. So basically, we are all dependent on how much data is fed and what is fed into the data. Beautiful movie again, which shows data is destiny and how it is going to get incorporated into clinical practice. Now, this gentleman, who's one of the founders of artificial intelligence, he said way back, almost about 4 decades back, the question is not whether AI can understand human feelings, emotions, and bias, but whether AI can be intelligent without these things. And he goes on to say that if a woman says, "Do you love me?" AI should realize that the S, of course, without emotional bias is the best available option to get some extra WhatsApp hour at dinner. And then AI truly understands a woman. And what we require is an AI that is developed both by men and women, so that we have an equitable place for both men and women in this. Now, over the decades, can AI understand women? Now, the natural intelligence perspective is yes, as good as humans. AI can understand female mood swings by decoding facial expressions, analyzing voice patterns, monitoring eye movements, and measuring the neurological immersion levels. But I put this onto the chat GPT just yesterday. Can natural intelligence understand women? And I just put it onto the chat GPT, okay? And it says, I asked, understanding women is beyond the scope of natural intelligence. Chat GPT answers, I appreciate your perspective. If you have any other questions or need assistance, feel free to ask. Have a great day. I rephrase my question. It says, I apologize if my previous response has caused any inconvenience. If you have any other questions and need assistance, same answer. So as in today, it's very, very difficult to understand a certain level of emotions beyond which we cannot understand. There are several issues on the gender bias, actually, gendered lens in the sense how you're projected. One person is projected. You take a picture and it's photographed. There's a beautiful study which analyzed umpteen number of images, and they've shown that the number of images analyzed on the female are less as compared to the males. Obviously, it is biased. So what it means is like you do any of your evidence-based surgery, evidence-based publication, you need to have some evidence wherein both are equal so that we get, it's not like we having a male-female ratio of, 90:10. It does not make any sense in artificial intelligence at least, but it makes sense in current clinical other publications. So as in today, it underscores and it shows that we need a lot of data, lot of inputs from various sectors so that we have good data input to make this an equitable thing. Again, I'll show you this picture, actually, just how pictures can be manipulated. Biden stepped down in favor of Kamala Harris. Very good thing, actually. The next day, we have this picture that popped up, actually. Again, it's a gender-biased image. The first image that popped up image, which showed the females in the background, completely, it's 90% of them are in the background. The first picture that popped up in the news was this picture which showed the umpteen number of females in the background. The next day, the same picture was again popped up. The background is completely blurred out. This is a bias because some male has done this and is blurred the entire images on the back to make sure that the people on the front are projected more than the people on the back. Now, how can we have this AI life cycle, we call it as, it is caused by basically exclusion of women at various phases of development of this AI. In this digitalization world, what we require is more and more of these people should get integrated. As we are saying, actually, please get involved into the thing. unless and until somebody comes forward and makes your presence felt in this field, then the same discussion will continue even in the next 2 decades. Women have to come forward to make sure that they represent themselves in this AI field so that, as you said, a female reviewer has got more female publications endorsed rather than a male. The same thing is happening on this side. So I think we require more women to come onto this field of artificial intelligence so that we have more of these data. And we require more of these women voices that need to be heard across, be it be on any platform, be it be on a social media platform, unless and until we hear these voices across, we cannot make artificial intelligence better. And it says that we need more women in AI to make better artificial intelligence in future. Now, these are bias for promotion actually, but these can always be used for any of these promotional activities or your position in the thing. Once the whole thing is put up, actually in the days to come, whether you like it or not, the corporate public sector hospitals will have these softwares incorporated into their HR systems. And they'll go by this, actually could be biased, non-biased, but I think we should be aware of this. So any place where they're having these systems developed, I think you should put in your views. There are ways to overcome this, like we have Sadiq has talked about this. Actually, the same thing gets incorporated onto the artificial intelligence now. Now, it is not only the men and women bias, actually, you have women and women bias also, actually. Nobody is talking about this, actually. This talks about this women and women bias. Rajita was talking about Botox. Suppose you get yourself Botoxed. Now, how can AI read the emotions of the person?
Not so much.
You get yourself screened today, tomorrow you get yourself Botoxed, and you want the AI to read day after tomorrow, it cannot read you as you are. So basically what you're trying to tell you is, suppose if you're masking your thing with what is happening in the current day thing, then it is very, very difficult for artificial intelligence to cope up with what is happening on this side, to make sure that you have naturally beautiful and then you project yourself naturally rather than trying to get any of these procedures done. AI is again gender based, irrespective of whatever it is. Actually, whenever somebody develops, we have most of these hardware, softwares have a female voice. Nobody has got it. I mean, you talk about Siri, you talk about Amazon, you talk about Google, whatever you talk about, they use a female voice to sell themselves. And again, a gender issue at Olympics. It's an issue between women and women, not against women and men. So there are a lot of issues which need to be addressed. Actually, we have a lot of strengths and limitations which are on the natural intelligence side, which if artificial intelligence gets incorporated, like Sadiq has very eloquently put it, perception, dedication, past, success, you're very good at this thing. But I'm sure that if this some amount of AI gets incorporated into this, we'll have better results in future. 21st century women aspire to lead in a way that fits their womanhood perfectly. Typical women strengths are their panoramic view, pro-social engagement, willingness to share power and networking. Female leaders should be aware of the drawbacks of this strength. They should develop strategies to cope up with these drawbacks. AI is becoming increasingly mainstream across all sectors and has great potential to benefit the society. The gender gap in AI is caused by exclusion of women at every stage of the AI life cycle, risking a vastly inequitable economic and technological system in the where digitalization is far advancing. AI has the potential to bridge the gender gap provided women take part in this. Possible by promoting diversity, reducing bias, fostering inclusive development, and we need to have concrete policies at various levels to make sure that AI does not go the way natural intelligence went. So, can AI, a combination of natural intelligence and artificial intelligence, understand women? I'm still not very sure. As in today, I'm not very sure with the evidence that we have whether we can understand women, even if you incorporate artificial intelligence into a perception. Thank you once again for the patient hearing.
this was an eye opener to us because, as you said, that if we don't get involved in AI and the inputs are again biased, the output will be biased. A very important point to be taken. And like once the info system came and we had the technical aspects of involving doctors into creating networking, LAN networking of hospitals, then many doctors took a role into that system, leaving their subjects behind. So some of us, maybe it's very difficult at the level of super specialist, but every field has to contribute to AI so that your presence is there.
Yeah, the
In
women
long-term
leadership
assessment.
to get involved into the thing and then make sure that it is involved.
So I think coming to the end of the discussions that have happened over the past 2 days, Sadik has kind of crystallized a lot of things that we've talked about. The bane, let me use a better word. One of the things that's happened over the past few years, these initiatives have been taken, is that there hasn't been enough follow-up action. So I think at least after this meeting, we should try and have enough follow-up action so that we get to some results by the time we meet again. Hopefully we'll meet again and we'll meet again soon in whichever form, wherever, but there should be some follow-up action that results from this meeting. Thank you, GV, and thank you, Sadik.
Thank you once again. Shall we end the, yeah, thank you so much.
I'd like to request Dr. Piyush sir to please hand over the certificate to Dr. G.V. Rao.
I would like to invite Dr. Sadik and Dr. Rajneesh to come to the dais. Sadaf, could you please stay? Yeah. And Dr. Swati, you could also come here. Sorry, I think, sorry, yes, sorry. Can Dr. Sadaf please give the certificate to Shreyas?
Thank you once again. Actually, I think it's getting late. So, on behalf of the AIG Hospitals, I'm not talking as a president, actually, on behalf of the AIG Hospitals, I thank the society for giving us this opportunity to do this meeting. I hope, actually, as Piyush has put in, actually, we have had good deliberations. Suppose we put it together and then take it forward. I think we'll be glad to do one more session of this, provided you are all very active. Your data, I mean, again, I keep saying your inputs are more important. Unless and until there is some involvement from this side, actually, it cannot be taken forward. And I think we should have more involvement from your side. I thank Sun Pharma for their support for this meeting. I thank my entire staff at AIG Hospitals, both operations team, the audiovisual team, led by Satya, for making all this possible. Thank you so much again. These people have been behind screen. Thank you, Sun Pharma, for doing this wonderful job. And they've promised me that they're going to extend this forward because of the huge success they have seen. Thank you so much once again. Can I request Rajneesh to just say a few words?
And thank you so much for to my president and the department in AIG and AIG team who have taken on the task of this of conducting this meeting. Expectations are obviously sky high, so I apologize if we have, as the society, we haven't met your expectations in this meeting, but we have our hearts in the right place. That I think probably we could convey. So maybe if you take one step forward, society can take 2 steps forward again. So I think it's kind of trying to meet halfway rather than expecting somebody else to solve all your problems. That's the way I would think. I would still expect, Dr. Sadik, would you like to make a couple of comments about how we can take this forward? That would be useful as a, please.
Yeah. now that Sadiq sir has said that we should have a women wing as a permanent part of ISG, and if you want to take cause, we cannot do much about gender bias as was discussed before, and you have taken the agenda forward of making women inclusive in academic activities. Another point which I would like to put forward on behalf of all of us is that in research nowadays we understand that many good journals require a lot of money for publications, which might be very difficult for most of us. And if you have some kind of competition in submission of research to the ISD, and if they can select one or two for women, because we came to know that there's a drawback of very little publication on that end, and it can be just one a year awarded to one of those bright people around.
Good suggestion. I think we'll certainly take this forward in the executive. And I should also a big round of applause to Sumana and Swati, who have been working on this for the last month. Thank you, Sumana. Thank you, Swati, for this. And the entire women team at AIG, thank you so much for your constant help.
Just a quick kind of expectation IASG has of this group, and that is if you want to take it forward, then maybe a good way forward would be to monetize this meeting and make some actionable points as to how we can move it forward. Making a wing ultimately is not our prerogative. It's the general body which decides. So maybe before that, a small task force can be made from your group who can take this forward. And the last culmination of that is a wing of, as you suggested, that can be ratified in the general body. The only thing is, my plea to you that is that the next general body is in October first week. So the time is short. We need to move forward on this direction if you really want to take this. Thank you so much.
I just no, I think
Dr. Shruti, the action points
we
are to be
should
coming
actually
from
write
your
the
end.
minutes of the meeting, and then we can discuss the action points accordingly. So that I will take care of the minutes of the meeting, and we can all discuss the action points.
I mean, I think what just going on to, we've been talking about this. My absolute suggestions are 4 or 5 names you should pick, make out the action points, designate people to take that forward, and gradually increase the group so as to be able to get the output from that. And as we said, we expect in at least in Patna to have something actionable at least to be done.
So we'll form a group and give that actionable points also. Before we conclude for the vote of thanks, I just dotted down. I mean, I was sitting there and I just wrote a few lines, and I want to tell that to all the women here. I think we are the privileged lot to be where we are today, and we should be grateful to all the people who have made it happen. Parents, family, teachers, colleagues, irrespective of their gender. There are more gender issues out there in the world to discuss and solve. Believe that you're a leader wherever you are. There is a shift in the world where the nature is trying to maintain a balance between Shiva and Shakti and yin and yang. We should try to become the balancers to continue to uplift every human, irrespective of gender, and become the leader in your own small groups. Like always said, little drops of water make a mighty ocean. Thank you.
So, first and foremost, I would like to thank the IASG for providing us with this opportunity to voice our concerns and talk on various issues that matter. Next, I thank Dr. D. Nageshwar Reddy sir for his ever presence and unwavering support so that this meet could be done in AIG successfully. I specifically thank Dr. G.V. Rao sir, Dr. Rajneesh Singh sir, Dr. Sadiq Sikora sir, and Dr. Piyush Sani sir for patiently listening to all the talks, opinions, and giving their valuable insights. This would not have been possible without your presence. Most importantly, I thank all the women in GI for actively participating and voicing their opinions on number of issues. All of you have raised some pertinent points, and like Sir said, maybe some action points will be formulated by the end of it. I thank all the chairpersons for accepting our invite in their busy schedule and coming here on weekends and gracing their presence. So last but not the least, I thank the AIG academic cell, the audiovisual team, and the logistics team, without whom this meet could not have been successful. Thank you, one and all.